Well, good morning, good afternoon, good evening to each and every one of you. I want to thank each and every one of you for being here today. To my understanding, 41 countries have registered for this, and we welcome all of you from all over. I was just saying that, we started the course series back in April, with the first one being Cornea Quarantine 2020. And that name was started homegrown by Dr. Carol Karp and myself. And the course was just inspired by the fact that, we wanted to lighten the load and just have fun in learning. And so after that, what came from that was the overwhelming feedback from senior ophthalmologists to medical students, really saying that they wanted more. And so that's how this was started, with the inspiration that may we provide expert quality ophthalmic education to those in the world that may not have access to it. Dr. Carol Karp, my hero from Bascom Palmer Eye Institute, was the very first speaker of the very first course, Chemo or Cut. And I am happy to inform you is here with us today. She is the professor of ophthalmology at the Bascom Palmer Eye Institute and the Richard K. Forster Chair in Ophthalmology. She has pioneered the use of interferon for the treatment of OSSN and has received a multitude of awards, including the Secretariat Award from the American Academy of Ophthalmology and the AAO Senior Achievement Award. I am honored that she will be introducing our keynote address from Dr. Carol Shields from the Wills Eye Institute. Dr. Karp, over to you.
Thank you so much. I first want to commend Dr. Narayani for putting together this series. As she mentioned in April, she is the one who decided to do this, and it really is to her credit that this whole webinar craze and excellent teaching has come about. She's a fantastic moderator and engages all the residents that are on. So you guys that are listening, you're really in for a fantastic treat. So thank you for this great honor. And Carol Shields is my great friend, mentor, inspiration, and I know we all feel that way about her. So it's really a great honor and pleasure to introduce her. It's really hard to put everything together of what Carol Shields is about. She is such a phenomenal individual. I had the pleasure of introducing her for the Gradle Lecture for the Pan American Society of Ophthalmology, and this is an updated version of all the wonderful things that she has done. So you know that Dr. Shields is the director of the oncology service at the Wills Eye Hospital and a professor of ophthalmology. What I'm going to share with you is a few more things about her beginnings. So she was number 6 of 8 siblings. She likes big families, as you'll see, and did her schooling at Notre Dame, which she was a fantastic athlete. So here she is on the basketball team in 1978, and she was number 11 there. And you can see her in action, always in everything that she does, doing a stellar job and reaching new heights. That's basically Carol Shields, who I affectionately call Big Carol. She calls me Little Sis Carol, and I call her Big Sis and Little Sis. She really always reaches new heights in everything that she does. So for published works, it's really unbelievable. Her original articles number more than 1,800. And when I put this together years ago to introduce her, there were 300 less. So in 3 years, she's done 300 more, which basically the math is that she publishes about 100 peer-reviewed articles per year. It's amazing. And for chapters, 335, over 800 lectureships, and her own textbooks, number 11. And I want to thank my son, Noah Karp-Cohen, for putting together these animations, which I could not do myself. In terms of academic honors, she has a multitude, which I could not. I would have to fill the entire 2 hours here to tell you everything about what she's done with the Donders Award, the American Academy of Ophthalmology Awards. She was the president of the ISO in 2013 to 15, multiple power listed #1, and induction into the Hall of Fame for the lifetime success in athleticism and career. And here is her getting an academic honorary degree from Notre Dame in 2005, which I know is very dear to her heart. She is a devoted mother and wife. She recently gave a beautiful lecture on balancing family and work life. So here she is, just a little while ago, with her family and her wonderful husband, Jerry, who I so admire and is listening on here, who has also been a great inspiration to all of us. And she's really someone who balances many things in her life with the utmost of grace and elegance. So in summary, she's an outstanding clinician and surgeon. She's just been an incredible researcher, author, educator, and mentor to so many of us in the world. And she's a devoted mother and wife, and really an inspiration to all of us. So it's with great pleasure that I introduce Carol Shields as the honorary speaker in this session. Carol, you are amazing, and we all so admire you.
Thank you, Dr. Karp. What a wonderful introduction. And, you know, I've always said you have to listen to your elders and to your youngers. And you are my younger, and I have learned so much from you over the years. I hope all of you listening to this webinar will realize the importance of friendship and collegiality. Carol and I are in 2 competing institutions, but we are best friends when it comes to discussing cases, sharing information, talking about what bothers us, what we can do better, and we always make it a point to help each other. And frankly, we enjoy speaking together in webinars and on the podium together because we are the 2 Carols. So that's our life. Thank you so much for the wonderful introduction. So my name is Carol Shields. I am the other Carol when it comes to ocular oncology. I do have financial disclosures. I serve on the Science Advisory Board for ARA Bioscience, and we will hear something about this in this talk. And I also serve on the advisory board for Immunocore, a new immunotherapy for uveal melanoma. So I'll be talking to you today on uveal melanoma 2020. What is going on in the world of uveal melanoma? We're going to talk about 3 things. We're going to talk about new risk factors to help identify nevus at risk for melanoma. We'll also talk about a new classification for melanoma from the National Institute of Health. And last, we'll talk about a new treatment that many of us on this webinar have been investigating together as a team for uveal melanoma. So let's begin with nevus risk factors. How common is choroidal nevus? Well, based on the Blue Mountain Eye Study from Australia, Archives Ophthalmology, 1998, the prevalence of choroidal nevus in a white population was 6.5%. We later looked at the NHANES database. It's the National Health and Nutrition Examination Survey from the CDC in Atlanta, Georgia. Mary Q, who was a resident at Johns Hopkins, joined us at Wills Eye Hospital, and we published this in Ophthalmology 2015. Looking at their database in patients over the age in patients 40 years or older, we found choroidal nevus was found in 5% of US adults. And there's a spectrum of choroidal nevus, from small pigmented lesions, as you can see in the arrows, to more amelanotic lesions, to larger lesions with RPE abnormalities and drusen, and to even giant choroidal nevus. So how often does nevus transform into melanoma? Well, the bottom line is it's pretty uncommon. But we did publish in Retina 2019 a study of 3,806 cases of choroidal nevus using imaging in every case to allow us to find imaging risk factors that predict transformation into melanoma. Bottom line, if you look at those 3,800 consecutive cases, only 1% showed transformation at 1 year, 6% at 5 years, and 14% at 10 years. This may seem high to some of you, but keep in mind, we are an ocular oncology center, so we get the most suspicious nevi referred in for our assessment. Using multimodal imaging in every case, we found 6 risk factors, some of which are similar to older risk factors that we judged clinically years ago. We remember these risk factors by this mnemonic: to find small ocular melanoma, doing imaging, where the T stands for thickness over 2 millimeters, F for fluid, S for symptoms of vision loss less than 20/50 on a vision chart, O for orange pigment on autofluorescence, M for melanoma hollow on ultrasound, and DIM for diameter greater than 5 millimeters on photography. These are really important risk factors, because if you look at these factors, the most important one is thickness over 2 millimeters on ultrasonography with a hazard ratio of 7.8, and fluid on OCT with a hazard ratio of 2.7, and orange pigment on autofluorescence with a hazard ratio of 3.2. These are the big 3 risk factors: thickness, fluid, and orange pigment. And we teach this to our fellows to recognize this, not just clinically, but on imaging. Now, if a patient has 0 risk factors, none of those 6 risk factors, they only have a 1% chance for growth in 5 years. But if a patient has 1 risk factor, it's up to 11% rate of growth by 5 years. 2 factors, 22% rate of growth. And the cutoff is 4 factors. If you have 4, 5, or more factors, there's a greater than 50% chance that the patient will show growth within 5 years. We use these risk factors every day in our practice to ascertain patients with low risk versus high risk choroidal nevi. So let's put it to work. Here's a patient with a flat 6.5 millimeter pigmented choroidal lesion with obvious overlying orange pigment. When we look at the risk factors, there's only 1 risk factor missing. That's thickness over 2 millimeters. This was a flat lesion. But this patient did have subretinal fluid on OCT. The patient did have symptoms of vision 20/50 or worse, and orange pigment on autofluorescence. And by ultrasound, you can see the melanoma was hollow on ultrasound with diameter greater than 5 millimeters. 5 of 6 risk factors. This is a 30-year-old man. Are you really going to watch this? This patient had a score of 5 risk factors with a Kaplan-Meier 5-year rate of growth of 55% and a hazard ratio of 26. This is a patient that we would strongly consider treatment at date first seen. Now, Lauren Dalvin, who's the chief at Mayo Clinic in Rochester, Minnesota, did a really good analysis. She combined all of these multimodal imaging features, 1 feature, 2, 3, 4, 5, and 6 features, published this in British Journal of Ophthalmology 2018. And she comprised this heat map, where this heat map shows those that were blue or green carried low risk for transformation, those that are yellow and orange, higher risk, and as you can see, those that are red have the highest risk, 70% chance or greater for growth within 5 years. We think this heat map will play into future artificial intelligence, with each nevus receiving a, quote, relative score of 0 to 100 based on the combinations of the 62 combinations of risk factors in this analysis. So I tell you, no more guessing or let's wait and watch. Let's be educated, let's be intelligent and use risk factors to score a nevus. Let's use smart science to score a nevus so we can prevent melanoma rather than waiting for it to happen. Now there's a new melanoma classification. This classification is based on genetics. Basically, those of us who take care of patients with melanoma all recommend that patients get fine needle aspiration biopsy for either RNA or DNA analysis. We prefer DNA analysis because it's much less expensive and it gives the same results. We search for chromosome 3, 6, and 8 abnormalities. With RNA analysis, which is a kind of a similar process, the patients found to have either class 1 or class 2. Now, if you look at chromosome 3 or 8 mutation, that's poor prognosis, or class 2, that's poor prognosis. And these patients are high risk for metastatic disease. That's the bottom line why we do genetics. We want to find the high risk patients so we can enter them into protocols to protect them from metastatic disease. Now, Robertson et al. Published recently in Cancer Cell Journal 2018 an analysis of uveal melanoma from the National Cancer Institute of the NIH. This was the Cancer Genome Atlas project, where they sampled 80 cases from many different departments around the United States and looked at a multi-platform molecular analysis, copy number, whole genome, RNA, DNA methylation, et cetera, and they came up with 4 molecularly distinct subsets of uveal melanoma. Those that have disomy, class A, or those that might have a disomy 3 with an 8q abnormality, class B, or those with monosomy 3. If they have monosomy 3, they become class C, and those that have monosomy 3 plus multiple 8q abnormalities are class D. And there's increasing risk for metastasis going from A to B to C to D. So we took the Cancer Genome Atlas and applied it to 658 cases to look at outcomes because they only evaluated 80 cases. So here you see our results. We found class A represented 52% of our entire 658 patient cohort. And the risk for metastasis in that good prognostic category was only 3%. It increased to 10% for class B, to 25% for class C, and up to 41% for class D, and this was statistically significant. So the Cancer Genome Atlas classification is an excellent classification based on cytogenetics, highly predictive of risk for metastatic disease. You can see the increasing risk for class A with disomy 3, disomy 8, class B, disomy 3, 8q gain, class C, monosomy 3, 8q gain, and class D, monosomy 3, multiple 8q gain with increasing risk for metastatic disease. This is important because we select class C and D for entry into adjuvant therapy protocols just targeted for high-risk patients. And last, I'll talk about a new melanoma treatment. This melanoma treatment is currently in the United States, but it's heading to Australia, to Europe, and all around the world. This new melanoma therapy, well, based on what we know now, we have several therapies for treatment of uveal melanoma: enucleation, plaque or proton beam radiation, resection, etc. We tend to prefer plaque radiotherapy. You can see this 9mm amelanotic melanoma before and after treatment with regression to 2mm. Plaque radiation offers 98% local control. So we got the local control in the eye sealed, but we'd like to have fewer complications. We get many complications after plaque radiotherapy, like radiation-related retinopathy, papillopathy with poor vision, cataract, glaucoma, scleral necrosis. And how can we reduce these complications? Well, we published in JAMA Ophthalmology 2020, just this year, on 1131 eyes with irradiated uveal melanoma treated with adjuvant bevacizumab or Avastin to prevent radiation maculopathy, compared to a cohort of 117 non-Avastin eyes who were irradiated. And we basically found that intravitreal bevacizumab, 1 year, it was 2040 versus 2060, 2 years, 2050 versus 2100, 3 years 2060 versus 2200. And amazingly, even when the patient was off the bevacizumab, the visual outcome was still better in the bevacizumab group at 4 years, 2070 versus counting fingers. Now, the drcr.net, the national study group in the United States that tends to study diabetic retinopathy or retinal vein obstruction, they're now studying prevention of radiation maculopathy, and Dr. Prithvi and some of the other members in this panel are cooperating with the DRCR, and we're devising a protocol now. Now, the new melanoma therapy is ARA-011 nanoparticle therapy. We finished phase 1b/2 study for safety, and we're now evaluating small melanoma, particularly those that have risk factors or are showing growth. We've done single ascending doses, multiple ascending doses, and expansion cohorts. We've now treated over 55 patients. Here's how the nanoparticle therapy is delivered. It's a viral-like HPV capsid nanoparticle that's injected into the vitreous, and it's attracted to the heparin sulfate on the melanoma cell, and it's coupled with a photosensitive drug that causes immediately cell death when exposed to laser light. This was first released in March 2017 after FDA approval. We treated the first 2 patients at Wills, but many patients around the United States and soon to be in Europe will be treated with this new therapy. Bottom line is visual preservation is found at 2 years and 92%. This is far better than plaque radiotherapy. Tumor control is 65%, which is worse than plaque radiotherapy. But we're working on better ways to improve this. The main safety issue is that it can cause anterior chamber and vitreous inflammation in most patients, but it's okay. We can treat with topical or subtenon's corticosteroids. We're opening a new trial now in the US where we're giving suprachoroidal delivery of this drug. So we basically take a needle that's 1 millimeter in length and inject it into the suprachoroidal space, as you see there in the bottom part of this illustration, inject the medication towards the melanoma. It saturates the melanoma, and again has a photosensitive dye on the end of the medication that's injected, so that when we shine laser light into the eye, it causes immediate necrosis. This trial is now open. Many of us are getting our IRB approval, and we hope to have good news to report soon regarding this new delivery. There are systemic protocols to prevent or treat metastatic disease for high-risk melanoma. We tend to prefer sunitinib. We published this in Ophthalmology 2017, where we looked at patients, 54 patients who were high risk treated with sunitinib versus 74 controls. They were all high risk, and the controls received no medication. But you can see it was significant. Those in the red line who received sunitinib, which was an oral medication given for 6 months, protein kinase inhibitor, had significantly better visual systemic outcome compared to those who did not receive any medications. And there was a even substantially greater benefit in younger age patients. Others are using dendritic cell adjuvant vaccination for the high-risk patients, and this is one report out of the Netherlands published in Ophthalmology. And then one other medication, again, we have financial interest in this medication. It's Immunocore, or immune modulated T cells against cancer, where a patient gets melanoma-specific infusion of a medication that is a bispecific molecule that has an HLA-A2 receptor that attracts to the melanoma and a CD3 receptor that holds the T cell and drags it into the melanoma. We've had patients with metastatic disease now alive for 4 to 5 years with this medication. Here's one such example of a patient with 30 liver mets, and you can see it circled here, showing her liver with the enhanced small metastatic foci. And 3 years later, after Immunocore, all of her metastatic disease is gone. But this does require weekly infusions. We have a long way to go before this goes prime time. Finally, pharmaceutical companies are exploring targeted therapies for treatment and prevention of uveal melanoma METs, now that we understand the pathways to uveal melanoma. So in conclusion, uveal melanoma 2020, we have now the 6 risk factors detected by multimodal imaging to find small ocular melanoma doing imaging. We image every nevus. We have a new melanoma classification, the Cancer Genome Atlas classification, which very simply uses cytogenetics to classify melanoma into A, B, C, D from the NIH. And then we have the new melanoma treatment that we're still working on, nanoparticle therapy, and we hope to show you in the future that it does provide excellent control with low risk for complications. Thank you.
Dr. Shields, thank you so much. That was brilliant. So we have a few questions. The first question is, how did you decide not the treatment interval for anti-VEGF prophylaxis after plaque placement?
That's a very good question. So let me just things. We know in the old days, the mean time to radiation maculopathy was 12 months and the mean time to radiation papillopathy was 18 months. So we decided to use this medication for 24 months. So we covered those 2 peaks. So that's why we do it for 2 years. I'm not saying this is all we need. Maybe we need to do it forever, but for right now, we know that 2 years does provide benefit. How do we choose every 4 months? Because we know that these anti-VEGF don't last more than a month in the eye. Well, these are patients who don't have radiation retinopathy. So we really couldn't justify bringing them back every month. So knowing that most of our patients travel long distances, we just coordinated it so they came back when we generally saw them on 4-month intervals. Now, others have done studies looking at 2-month intervals and found benefit with 2-month intervals. So we have to work out whether 2 months or 4 months is for the patient. With the DRCR, we're going to be looking at 2-month intervals.
Okay. And next question is, what is the role of proton beam therapy, Dr. Shields?
Yes. So the question is, what is the role of proton beam radiotherapy for uveal melanoma? Proton beam and plaque radiotherapy, I should always say in the same sentence, because they are equivalent treatments for uveal melanoma. With iodine plaque radiotherapy, we can treat up to 15 millimeter in thickness, same with proton beam. Ruthenium radiotherapy, 5 millimeters in thickness. So there's a little bit difference depending upon the isotope you use. But we believe that both treatments offer similar tumor control, and in my heart, I think similar complications, even though earlier studies showed proton beam had more complications of glaucoma. I think nowadays with anti-VEGF, that's kind of, the playing field has equaled out. So I think they're both excellent treatments.
2 more questions here, Dr. Shields. What is the risk of seeding and metastasis after fine needle aspiration cytology for suspected melanoma for DNA RNA studies?
Yeah, another good question. So all of us are very careful when we do fine needle aspiration biopsy. We try not to disturb the tumor. We personally go in with a 27 gauge needle on a connector tubing to a 10 cc syringe, and we slip it in, take our sample and slip it out. And in our cohort, we've done about 5,000 FNABs now for cytogenetic testing, and we've only had 2 patients with extraocular extension. So it's very, very rare. One was an elderly gentleman who had a very necrotic tumor, and we did his biopsy. He went to the scleral part of the tumor, and I remember this case. A little bit of gush of necrotic material came out. Once you see that, you have to be very careful. We prefer to do all of our biopsies through the pars plana because we think it's much, because you have the vitreous buff. Do we see vitreous seeding? So you can sneak in and out of the eye if you're using just a needle. I can't say the results are the same doing a vitrectomy, and some people like to go in with a needle because it's less damage overall. Very rare to see tumor escape.
And Dr. Shields, what is the role of liquid biopsy in uveal melanoma?
Wow, so another really good question. And we have perhaps the world's expert on this in our panel, Dr. Jessie Barrett. She was the first to report on liquid biopsy for any intraocular tumor for retinoblastoma. Now we can do liquid biopsy for retinoblastoma by sampling the aqueous, liquid biopsy for lymphoma, vitreoretinal lymphoma by sampling the aqueous, and we and others are now investigating liquid biopsy for uveal melanoma. It might not be the same yield that we have with retinoblastoma, but we'll wait and see what results get published. And when Dr. Barry's up, or if you want to ask her her opinion on liquid biopsy, because I know she's done a lot of work on this.
Sure, thank you. Dr. Barry, would you like to chime in on this question?
It's if Carol Shields ever calls you an expert, that means that you you get to ride on some joy for a while. Thank you, Carol. That's a
you are the expert.
That's a huge honor. If my eyes bugged out, it's because I didn't expect
being recorded
that. Thank you.
too, Jessie.
So yeah, I mean, as Carol said, we are doing some aqueous liquid biopsy for intraocular tumors. I agree with Carol because the question was related to uveal melanoma, that the type of tumor that a uveal melanoma is far less necrotic than retinoblastoma. And so the yield in the aqueous seems to be less for that disease. Liquid biopsy can also refer to blood-based mechanisms. And that may actually kind of have a higher yield for uveal melanoma, which is known to have a much higher rate of metastatic disease, at least in the US, than retinoblastoma, which has an overall low yield of tumor DNA in the blood. I'm happy to talk about that more later.
One question to Jessie. Have you been seeing a higher yield with iris melanoma? Do you have any experience with that?
So we actually, I can tell you that in a week. We actually just took a first sample from an iris melanoma. And I actually think that after radiation, there seems to be a slightly higher yield. So basically you need to disrupt the tumor in some way to get enough DNA into the front.
So I'm gonna ask if anybody else, any of the participants have any questions. We'll take one more question. If you wanna unmute yourself and ask Dr. Shields before we move forward.
I'm Dr. Shravan. I'm an oncologist. I'm from Bangalore. Okay, I just want to ask what the role of immunotherapy, systemic immunotherapies in uveal melanoma. Because in a systemic, like peripheral melanoma, there is a big data coming up with the improved survival and over like PFS. So what is that role, immunotherapy, systemic immunotherapy role in uveal melanoma?
Great question. So Dr. Shields, what is the role of immunotherapies?
Yeah, so I hope before I retire, hopefully not for 20 years, but I don't know. I hope before I retire, we have the answer to this. So what do we know now? We know that checkpoint inhibitors, that new class of immunotherapy for skin melanoma, doesn't work very well. We only get like a 5% response with uveal melanoma, so it doesn't work very well for uveal melanoma. We do have and the Dutch, we have vaccines. These are used to treat either patients with METs or patient at high risk for METs. My ultimate goal is all patients should be on immunotherapy or some sort of therapy to prevent metastatic disease from uveal melanoma. But right now we have to work at it in a very organized fashion. We're only allowed to treat patients with metastatic disease or selectively take those that are high risk under protocol and treat them with immunotherapy. I think the next few years, we're going to see a slow transition to prevention of metastatic disease. That's my goal.
Dr. Shields, thank you so much for that, really. And as questions come up, we'll make it informal and allow for anyone to unmute themselves later on and ask the question, or they may Feel free to put questions on the chat box, and so we can keep it interactive. So I think the one question that didn't come up is, Dr. Shields, how do we become like you? And I think that that's a rhetorical question, and I think it's going to take a lifetime of getting to know you more and more and more to really, really learn the beautiful qualities that you imbibe in your life. So up next, we have the 411 on OSSN multiple choice questions. The first question is inspired from the comparative analysis done by Dr. Carol and Jerry Shields that has been submitted for publication. Thank you, Dr. Shields, for sending this over so that we can not only be up to date on 2020, but 2021 as well. So the first question goes to Dr. Ankita Tali. Which of the following is similar regarding ocular surface squamous neoplasia, OSSN, in smokers as compared to non-smokers? A, similar rates of new tumor. B, a similar response to topical interferon alpha 2B. C, similar tumor sizes. Or D, similar rates of inferior fornix involvement.
Good evening, ma'am. I'm not sure if the answer is B. That is similar response to topical interferon alpha 2B.
Absolutely. Great, great, Dr. Thali. That's excellent. So let's go through it. This comparative analysis of 12 tumors in smokers versus non-smokers. It was observed that there is a greater tendency for OSSN in smokers to be larger, more often bilateral, to have more recurrence, new tumor, and involvement of the inferior fornix. There was a similar response amongst the two groups in interferon alpha 2B. And the clinical pearl here is that, especially in smokers, but always examine the inferior fornix and the contralateral eye. A very important thing for our residents online is to do a very detailed history, know about sun exposure, smoking, immunocompromised status, autoimmune status. Very important to use your clinical examination skills to hold down on those inferior eyelids. So the next question goes to Dr. Shruti Jeswal. Which of the following represents OSSN on anterior segment OCT optical biopsy? Give your best shot.
Is it C, ma'am?
Absolutely, perfect, perfect. So if C is OSSN, then what do you think A, B, and D are? So with C being OSSN, we've got amelanotic melanoma. Of course, maybe not the amelanotic part, but knowing that A is melanoma, B is lymphoma, and D, amyloidosis is important. And I emphasize this to my residents to know this. So this is a great, this is off of a great paper by Dr. Carol Karp in the AAO iWiki in March of this year, identifying the anterior segment OCT findings of various corneal pathologies. So let's go through this, okay? Most importantly, to know whether it's epithelial in nature or subepithelial location. So with OSSN, it's an epithelial lesion with the classic pattern being thickened hyperreflective epithelium and an abrupt transition between normal and abnormal tissue. The other 5 lesions here are all subepithelial.
What I like to speak to my fellows and residents about is, first is determining whether this is an epithelial lesion or a subepithelial lesion. And it's always helpful to look at multiple different cuts of the OCT and find the normal epithelium, which you know is going to be dark and thin. And so, as Dr. Narayani already said, OSSN, ocular surface squamous neoplasia, is an epithelial disease which is characterized by thickened hyperreflective epithelium and the abrupt transition, which is what you saw in see on the last slide, and when you look to the bottom here, you'll see that in each side, you see that little red itty bitty arrow where there's the abrupt transition to the thickened hyperreflective epithelium. So next, talking about epithelial diseases, conjunctival lymphoma, which you saw on the last slide, has a very monomorphic. Those cells are all the same. They're all babies from the same mom, same cells. So they have a homogeneous appearance, and the epithelium is normal, and you can often see the conjunctiva displaced. Almost looks like a pseudocapsule, or sometimes it's just the layer of epithelium. So, but it's monomorphic and it's dark. That last one, which was, I think, D, with conjunctival amyloidosis, that's not something you see very commonly, but I have to say we saw it yesterday, and I was able to show my fellows, yeah, there we go, that on D, this is not something you'll see a lot of, but it's really helpful when it does, because we had an unusual presentation, and that OCT is very classic, where you see these lines in the subepithelial space that can be very suggestive for amyloidosis. And then melanoma is it's always a subepithelial disease. Sometimes the epithelium is also involved because, say, for instance, with a nevus, you may have early on some changes in the epithelium, but this is a subepithelial disease, and that is much more hyperreflective in nature. It's good to know pterygia, because often OSSN and pterygia are combined. I would say here, when the pterygium where it says epithelium is normal, the epithelium in a pterygium is normal thickness, but it is often hyperreflective, but it's thin. It doesn't have the three characteristics. So when you're looking at a pterygium and wondering if there's a little foci of OSSN, if you see thickening, that's abnormal. If you see some hyperreflectivity, that is a normal actinic change that happens on the conjunctiva. And the main thing in pterygium is the stringy hyperreflective that you can see down on the bottom there, that's subepithelial. And nevus, as many of you all here have seen and published, is characteristically has these conjunctival cysts, and that's a subepithelial lesion, although in young kids you can see some junctional epithelial activity.
Lymphoma, amyloidosis being your homogeneous hyporeflective lesions, your melanoma and pterygium being your hyperreflective lesions, and really look for your cysts in the conjunctival nevi as a sign of chronicity. So anterior segment OCT is important for diagnosis, but it's also important for monitoring progress of topical chemotherapy. And this is out of the Duke manual that is in the works of a case of a 69-year-old Hispanic male with classic signs of OSSN on anterior segment OCT with the thickened hyperreflective epithelium and the abrupt transition between normal and abnormal epithelium on the top right. And then you can see that after 4 weeks of 5 cycles, I should say, of 5-fluorouracil, there is clinical resolution of the OSSN with normal hyporeflective epithelium. And not only that, but we can also use it to identify surgical margins. So this is a case of mine of invasive squamous cell carcinoma. And what I put together is what I call an anterior segment montage to help me identify my surgical margins more accurately. And so the clinical pearls here are performing an optical biopsy with anterior segment, either high resolution or ultra high resolution OCT can help differentiate OSSN from other anterior segment surface lesions. Anterior segment OCT may be used to monitor OSSN progress while on topical chemotherapy and to identify surgical margins. So the next question, inspired by Dr. Karp's paper on OCT angiography. On OCT angiography, which of the following was found to be true regarding the vessel area density, or VAD, in cases of OSSN? Is it A, there was a higher VAD within the tumor as compared to the adjacent subepithelial tissue. B, the VAD within the corneal component of the tumor was significantly higher than the conjunctival component. C, the VAD under the corneal and conjunctival components of the tumor were similar. Or D, there was a higher VAD underneath the conjunctival component of the tumor compared to within the tumor. Alrighty, well, the answer is A, and we'll go through it, okay? This was an excellent paper from April 2020. And so if we say that clinical exam and history are our right hand, left hand being anterior segment OCT, I think I'm gonna have to develop a third hand to really understand OCT angiography and really start to know the characteristic signs. So this was a cross-sectional study of 15 optical biopsy proven OSSN patients. These were not taken for surgery so that we would be able to identify the architecture best. And what was found was that the vessel area density was highest within the tumor, followed by adjacent subepithelial tissue and the tissue underneath the conjunctival component of the tumor. That the VAD was higher in the tissues of the involved eye as compared to the non-involved eye. And it was significantly higher within and under the conjunctival components of the tumor rather than the corneal component within and in the tumor. And this was one of the cases in the series that I want to highlight. It was a 38-year-old patient with a leukoplakic head of OSSN, as we can witness in A. I want to point out a few things from here. As we can see in C, you can appreciate the blood flow going through the epithelial and the subepithelial layers. In D, it's a tumor thickness map, so it's notable that it's thickest at the leukoplakic head. F and G represent en face angiographs. F representing more superficial layers, and so what we can appreciate here is that the vessel area density, the white strands that you're seeing there, the white lines representing the density of the vessels, are more profound on the conjunctival side than on the corneal side. G, going deeper into the subepithelial layers, we can appreciate the plexus of the vessels in the subepithelial layers adjacent to the tumor. And this is a beautiful image from Dr. Carol Shields in ophthalmology in May of 2020 of squamous cell carcinoma in situ in a 66-year-old female with a gelatinous OSSN. And you can appreciate the florid intratumoral thin vascular networks on the top right. So before we go on, I want to open it up to Dr. Shields and Dr. Karp to give their input on OCT angiography and where you see us going with that in the future for OSSN.
I'm not sure yet what role OCT angiography is going to have for me in helping my treatment yet. I don't know. I think at this point, I see it as a learning tool in terms of understanding the vascularity of tumors, how they regress with treatment, with topical treatment. And so that's what I'm really learning about. And in terms of my treatment or guiding my treatment, I'm not sure yet. We're looking at these in the different phases of treatment. So I would say right now, it's really helpful to me in just understanding what happens with tumors and angiogenesis in tumors, but I'm not sure how it's going to help guide my treatment.
Okay, thank you for that. And Dr. Shields, any points on OCT angiography for OSSN?
Yeah, first of all, it's very difficult to do, to find a cooperative patient. They're usually elderly, sit still long enough to get a good OCTA. And the other reason it's difficult to do is because these are elevated lesion. So you have to section the lesion. Your photographer has to place the cursors where they believe the vessels are going to be, because it's not a flat cut like you get with the standard OCTA. So it's difficult to do. And like Carol Karp said, there may be a role for this at some point in the future. I would estimate that of 50 patients, if we did 50 patients OCTA, maybe 25 would have decent ones and 25 would have worthless ones. So it's hard to do right now.
Thank you, Dr. Shields. So in an interest of time, I'm just going to pull up the pearls from this question and then wrap up. And this is courtesy of Dr. Shields in a conversation we had last weekend. What do we do when interferon alpha 2b just does not work? Most importantly, we have to check patient compliance, switch to injectable interferon alpha 2b, investigate for an immunocompromised or underlying autoimmune condition, and then if all else fails, switch to 5-fluorouracil. And remember, the dosing for subconjunctival is 3 million IU on a weekly basis compared to the topical interferon alpha 2b, which is 1 million IU per ml. And finally, clinical pearls, medical versus surgical. Not all OSSN suspected lesions require surgical excision. In non-invasive cases, medical therapy with topical chemotherapy alone has shown great success without excision. And finally, in cases of recurrent, large, or annular OSSN lesion, medical therapy is preferred over surgical intervention. And so we do have the steps that'll come up on the recording, step by step of OSSN excision. But in an interest of time, I just want to focus in on a video courtesy of Dr. Shields on the importance of really getting at the base of the OSSN tumor and getting all of the tumor excised. Dr. Shields, any points on this?
Point number one, we don't use any BSS. We want the surface dry so we don't see cells. Number two, we never touch the tumor. We only handle normal tissue. And number three, we always freeze the margins, lifting the conj off the sclera so that we don't freeze the retina. And then we reconstruct double layer fashion with tenons first and conjunctiva epithelium second.
Thank you.
Dr. Carroll, I think another issue that goes to compliance is also the cost of the medication in different countries. So in the United States, for example, interferon, though it works great, is expensive. And as I've now practiced on both coasts, I can see a clear distinction in the ability to get that covered. Now, our colleagues in other parts of the world may have it much easier to get these drugs at cheaper costs. So sometimes we have to be creative, as your slides pointed out. We bring them in for administration of subconjunctival injections, which gets billed on a different kind of docket. So sometimes the patient doesn't get those charges that they have to pay out of pocket. And for where I am now, 5-fluorouracil is easy to get and inexpensive for the patients relatively. So that's kind of shifting to more of a frontline treatment. And I know Dr. Karp has talked about this in some of her excellent lectures in the past.
Dr. Karp, do you want to chime in on this?
I completely agree. So part of, I think the important part of the treatment is that the patient gets the treatment. And if they don't get the treatment, it's not going to work. So I think the point is very well made that in different parts of the world, different drugs are more available, more costly, or less costly. So in India, you guys have the advantage of interferon costing $1, and for us, costing $800 for a month's supply. So I like to joke that it's probably less expensive for the patient to go to India, see the Taj Mahal, stay in a nice hotel, get their OSSN treatment than it is to do that in the States. But 5-FU is super economical, easy to get, and many logistical factors. So we have to think of the whole picture of the immune system. And Dr. Narayani said that was going to be better with a 5-FU. A patient who can't get drops can be better with injection, etc. So it's important to look at the whole picture of we're going to get that drug into the.
Great. Thank you for that. So next we have Dr. Prithvi Mrityunjaya. Dr. Mrityunjaya is the Director of Ocular Oncology Service and the Director of the Vitreoretinal Surgery Fellowship at Stanford University Byers Eye Institute. Before that, he was Director of Education at the Duke Eye Center, Medical Director, Director of the Duke Center for Ophthalmic Oncology, and the Director of Grading at the Duke Reading Center. He's the recipient of numerous awards, including the Senior Honor Award by the American Society of Retinal Specialists, the Golden Apple Teaching Award at Duke University Eye Center, and I remember that fondly when he received that. Ocular Surgery News Top 150 Retinal Specialists in the World, and the Senior Achievement Award by the AAO. He is extensively published and has been an invited speaker on numerous platforms internationally, and is currently guest editor of the Current Concepts in Ophthalmology Special COVID-19 edition. So it's perfect, it's actually opportune that we hand it over to him to talk to us about A Tale of Corona, Ocular Oncology, and COVID-19. Thank you, Prithvi.
Thanks, Ashiana. It's really a pleasure, and what a wonderful course you've set up here. I remember Ashiana as a cornea fellow at Duke. She was just outstanding and stellar. I would share many of our patients with anterior segment tumors, and she really showed a great interest in that, and thus her practice now has evolved to taking care of so many in India that have these difficult conditions. I would, again, how great to see everyone from so many different countries here this morning or evening, depending on where you are. I'm going to talk today a little bit about personal anecdotes as we are all in this very bizarre, unique experience with coronavirus in our practices and in our lives. So I don't claim to be someone who has a cure in the making. I'm not developing vaccines. I will say I do wear a mask and I socially distance. That's as far as I can go for trying to solve this problem. But through a series of very interesting coincidences, I think I've been involved in a couple of scenarios with coronavirus in its early stages that have influenced how myself and my colleagues have approached this condition. So let's get started, and I'll share some of those stories with you. Here are my disclosures, none of which are relevant. I think the most important and most sobering fact is this data slide from Johns Hopkins University. So there are nearly 20 million global cases confirmed and nearly 750,000 of global deaths, which is just a staggering and unbelievable number. Here in the United States, apparently we like to be first and best, and unfortunately this is a sobering statistic for a number of cases in the United States. And my friends and colleagues in India are unfortunately not that far behind at over 2 million confirmed cases, and probably due to a limitation in access to testing, that number is probably underrepresentative of the overall problem. So this is clearly an unprecedented time and a global situation. We know that when we look at the medical implications of how we as physicians have to manage our patients in the setting of the COVID virus, there's a couple of points that come up. One is equity or inequity in terms of allocation of resources, time, ability to help all patients equally as you would if this weren't the pandemic. The second is the availability of protection for physicians and staff. The third is how do you protect patients and using concepts of social distancing and wearing a mask. And then finally, how we as surgeons, ophthalmic surgeons, manage our patients in the operating room. So our story with COVID-19 in Palo Alto, California may be different than your story in your part of the world, but let me share a couple of points that kind of impacted how we've kind of evolved ourselves. So we know January 30th, the World Health Organization declares this a global health emergency. The first case in Northern California was found on January 31st. We know that Santa Clara County, which was the county that Stanford University is based out of, declared a health emergency relatively early on February 6th. And you may remember in the news, there was several cruise ships that were stranded because their passengers had been positive for COVID, and they had to be carefully escorted off the ships, and they were docked here. So the Diamond cruise ship docked here in Oakland, California in mid-February. And in March, things heated up. So the governor, Gavin Newsom, declared a statewide health emergency in March. And one key point that probably impacted how transmission changed in our area is that in Silicon Valley, there are very large tech companies. So Google, Facebook, Apple. So those companies went remote fairly early in March. So we had a large proportion of the workforce that was taken away from general population contact, and I think that made a difference. March 13th is a critical time in my family's life because that was the last day of school. So schools closed after that Friday, March 13th, and we went to a shelter-in-place configuration that Monday afterwards. So that was kind of our initial rapid evolution and confusion and trying to kind of sort everything out. So this brings me to a case that I think is pertinent to this discussion. So this is a 69-year-old male from Chico, California, so up in the mountains. In August of 2019, he was diagnosed with rapidly progressive astigmatism in one eye and a rapidly developing cataract. In February 2020, he underwent cataract surgery, and as the surgeon was about to perform the capsulorhexis, the surgeon discovered an intraocular mass intraoperatively and aborted the surgery. The patient was referred to our center by his local hematology oncology physician because he has a history of Waldenstrom's macroglobulinemia. He's on active treatment and a previous history of testicular cancer. So we can see his right eye is normal, but his left eye has decreased visual acuity. He dilates poorly. We can see that there is an asymmetric cataract, but also an infranasal iris defect that's suggestive of a posterior mass. We can see that it was rather large on ultrasonography with low internal reflectivity consistent with a ciliocoroidal melanoma. So while planning for surgery, a couple things happened. Well, first, he had screening scans looking for metastatic disease. So he had a CT of the chest that was initially read as essentially normal, maybe some atelectasis, but he also had a cough, and he describes he's had a chronic cough and he had no fevers. And this is the time we were just trying to figure out what symptoms are important. Can you go by symptom management alone? And he had a COVID-19 nasopharyngeal test, one of the early generation tests that was positive. So this is a complicated situation. So we have a COVID positive patient. The CT scan was reread as possible signs of COVID infection. He had maybe flu symptoms as well. He has Waldenstrom's, and he's also on ibrutinib, which if you're going to take a patient to surgery may have an implication on their anticoagulation status, but also if you take the patient off for a prolonged period of time before surgery, that could impact the status of his Waldenstrom's. So it was a complex situation. So we followed up and had great conversations with, at this, one of the largest multidisciplinary groups I was involved with anesthesia and OR management and hem-onc and infectious disease, to try to figure out what was the most appropriate next thing to do. So we had repeat tests, and we got into all issues of tests not being available and where to find them, and which tests could come back fast enough. And finally, we had several serial negative COVID tests, and we felt that he was asymptomatic. So we proceeded with trying to figure out the timing of surgery, where in the ORs, which were all essentially closed for elective procedures, do we step in to do this? We figured out what type of protective equipment was appropriate for us, and then we finally took him for enucleation surgery. So here we can see the imaging of the large tumor. We also did COVID staining of the enucleation specimen to see if there were any other ocular tissues that were involved. We're all aware that there's reports of conjunctival involvement from COVID positive patients, but we were unable to identify in a recently positive COVID patient any signs of viral particles in any layer of the tumor itself. So at week 1, we did a video visit, and he had his prosthesis delayed by a few weeks to about 3 months and is now doing fine. So what is the world response in ocular oncology to COVID? And I think that everyone's been very thoughtful, very engaged, and cooperative and collaborative in trying to figure out how best as a field of ocular oncology do we take care of our patients. Now, our patients are unique. They have cancer, they have systemic implications for their disease, and many are under active treatment, and they're all still dealing with the same issues that all of us are, their general health, their fear of being exposed, the personal work status of patients and their families. Do they have jobs? Do they have insurance? Do they have access to healthcare? Can they travel in these times? So these recommendations are based on several layers of data. First is anecdote. Second is real world snapshots, show what others in the field are doing, and maybe that can guide patterns going forward. There's expert opinion, consensus statements, and what we don't have are validation of these with clinical trial data, which is difficult to do in the midst of a pandemic in the real world. So this is where my March and April and May were involved, working with colleagues from around the world on several efforts to try to understand how we as ocular oncologists should approach this COVID situation. So I'm fortunate to be part of a multi-center NIH-funded study called the Collaborative Ocular Oncology Group Study Number 2, headed by Dr. William Harbour at Bascom Palmer, and I serve on the executive committee for this. And we, as ocular oncologists that span multiple practices across the country, were interested in what was the on-the-ground response on the fly for taking care of patients in this COVID situation. So 3 SurveyMonkey surveys were sent out to all of our 25 participating sites. One was in March, one was a few weeks later in April, and another one in June to see how things stabilized after 2 to 3 months. We looked at active practice patterns for patients with retinoblastoma, melanoma, high-risk nevi, metastases, lymphoma, and conjunctival lesions, and these results reflect an on-the-ground reality. This was also disseminated on the website of Castle Biosciences, because this does not represent a paper that we felt would get out fast enough. And this was also reported at the American Society of Retina Specialists and the AAO to help provide guidance for its members. So these are some of the questions that we would ask our participants. So we're looking at how do you prioritize the timing of the next EUA in patients with retinoblastoma. And we tried to divide it by patient's age and genetic status. And we were trying to figure out whether these were managed as usual or delayed, or would you move to enucleation in some of these patients because of inaccess to care? And what we found was that this unknown and maybe reactionary response in March that stabilized in April and to kind of be less follow them up. And some would decide about managing as usual, some delayed their follow-up, and some started using telemedicine that seemed to be more and more common as the surveys went on. Here's a question about prioritizing timing of enucleation in patients with uveal melanoma. Most would still push for prompt enucleation regardless of systemic status, but some would delay enucleation, which is again based on the ground situations. How about intraocular metastasis? Wow, we can see that there was a big spread between when patients were followed up and even the use of telemedicine for looking at posterior segment metastases. And here also we can see with looking at patients that did not have very high risk lesions that were being referred in. And again, patients were being delayed in many centers, and the use of telemedicine. And then finally, conjunctival disease. What would end up happening is either the patients were not thought to be priority and then spaced out a little bit. Some would start topical chemotherapy before doing any surgery. So there was clearly a shift towards trying to avoid patients being in the operating room. A second effort was an expert opinion, which presented as a letter to the editor to the journal Ocular Oncology and Pathology, and it was headed by Alison Scallett, and I was honored to be on this with Dr. Carol Shields as well. This was taken as global correspondence, so basically call a friend, email a buddy, see what they were dealing with in their practices in different parts of the world. And it tried to come up with best practices in ocular oncology. It defined timeline and priority, and the goal was to help the patient try to get the care that they needed, and the surgeon to try to help them get traction and leverage in their own institution to be able to take care of those patients. And we recognize that there's differences in various settings. And this was actually endorsed by the American Association of Ophthalmic Pathologists and Oncologists and the board of the International Society of Ocular Oncology, which I think is important to have that buy-in from these various institutions. This divided patient cases into emergent, which means needs to be done as soon as possible. So these were patients that had suspected orbital rhabdomyosarcoma or who needed enucleations. Urgent cases, which should be completed within a week. So care of retinoblastoma was prioritized, orbital decompressions. Semi-urgent, which was within 1 to 2 months, so taking care of our retinoblastoma patients, uveal melanoma treatments, and then diagnostic biopsies as we need them. And finally, non-urgent, which was de-emphasizing benign tumors and conjunctival lesions. The efforts in India across ophthalmology by the ophthalmology community in every subspecialty in India has been just outstanding. Amazing documents that have been put together by expert opinion and guidelines that have come forth. Here's a paper that was published, again, with an expert opinion consensus panel looking at preferred practice patterns for ocular oncology care in India during the COVID-19 pandemic. Dr. Manjan Davida and colleagues published this in the Indian Journal of Ophthalmology in 2020, and they looked at various stages of triage, which I think is very important. So online registration by questionnaire, triage level 2 is teleconsultation, level 3 is clinic visits, and then level 4 is clinical evaluation. And carefully across every ocular oncology condition, they came up with very, very detailed guidelines, how to manage care, how to manage surgery, how to prioritize. So I was very impressed and applaud these efforts. In the United States, the American Society of Retina Specialists also got involved in trying to figure out the rationale for how we recommend practice patterns. And I was honored to be on this panel as well, and we published our guidelines online as early as mid-April, because we wanted this to be available to our fellow retina specialists who are ocular oncologists as well, to have access to this information. And an editorial was submitted to the Journal of Vitreoretinal Disease with endorsement by the American Society of Retina Specialists, the Retina Society, and the Macula Society, of which Carol Shields is the president. So she was very instrumental in helping us gain consensus. And the purpose was to provide interim recommendations on best practices to perform vitreoretinal surgery to protect surgeons, OR personnel, and patients. And this is available online, but I'll point out that this methodology was different from just calling a friend. So what we tried to do was establish initial levels of confidence for recommendations. We, based on an adjudication, we raised or lowered the level of confidence, and then we had a final level of confidence rating. And then based on this, we decided the determinants of the strength of the recommendation, and then we had to consider the implication of the strength of the recommendation, both at a population and a policy level. So this is yet another way to try to get recommendations that make sense, adjudicated, validated, and then brought forward to our colleagues and ultimately to our patients. So I'll end with talking about some novel solutions that have evolved during the COVID-19 situation and focusing on clinic safety, telehealth, e-pathology, and e-conferences. So this is my new look in clinic. No longer wear a shirt and tie, unfortunately, but I am armored up from head to toe. What we're doing in our clinics, which many of you are as well, is we're screening patients at the door. We are giving masks to everyone who walks in. Even if you have like 3 masks on, we're giving you a clean one. And our purpose is we have availability of them, so we feel fortunate. And we want to put clean masks into the general population. So we want more good masks out there, even if it's for one patient, one family member, that's great. We're limiting how many patients come into the clinic at a given time. So no visitors with the family members, or maybe one, especially in children that are coming to the clinic or older individuals. Patients check in and they wait in the car, and we're working on remote check-in so they don't even have to step in until their appointment time is ready. We've moved our imaging equipment to create imaging pods next to the clinic's lanes themselves. So there's a shorter transit between where a patient is going when they check in and get screened, get their imaging done right outside the clinic rooms, and then go straight to the clinic rooms to minimize time in waiting rooms. Our department has started drive-through intraocular pressure checks for glaucoma. We're cleaning like crazy and washing our hands and sterilizing everything that we possibly can. We're trying to balance our schedules with all practitioners within our retina group specifically, so that we don't have crowding of patients, especially for imaging. And before surgery, all patients are getting COVID tested. And I'm sure many of you have implemented these and other great recommendations as well. So the second is telehealth for electronic visits. So managing patients, patient care remotely is something that has been tried on many levels prior to this COVID epidemic. It's technology driven, but in the United States, government restricted. So there was not proper reimbursement and a lot of hurdles in terms of regulations as to whether you could or couldn't do this. So it really wasn't being done. Though everyone wanted it to be done, it just wasn't happening. But when access to care became limited, the rules suddenly changed, and it all came down to billing. So Medicare, which is our government healthcare system for elderly patients, now allows physicians to bill for professional services nationwide in the United States in all settings, in person, at home, via FaceTime, Google, Zoom, and they waived a lot of the HIPAA requirements as well. In addition, private payers now can offer no copays for telemedicine visits, and it expands the ability for telemedicine across state lines in some cases. So all of the restrictions completely gone like in one fell swoop. And the hard part is that it applies great in certain fields of ophthalmology, but not all of them. So here's an example of the interface that I have through our integrated electronic medical record. So the patient is given an appointment, and that appointment allows for their visit to show up as a e-visit. We can discuss with them. We can also do this through a secure email situation where patients take pictures and then send them in, and we can discuss that. We can also use Zoom if everything fails, or whatever method. They really kind of don't care at this point, as long as you can document it. How have I used video visits for my patients? I can't say use it all the time, but I use it for a lot of post-op week 1 surface healing checks. The patient kind of brings their eye really close or takes a picture and I can see it. I review instructions with patients. For new or follow-up visits, I integrate imaging data either from outside doctors. So here's an iPhone picture sent from a referring physician that I could then use to integrate my discussion with patients who are unwilling or unable to make the trip to see us. And then decide if a patient actually needs to come in. So, and that kind of helps with reassurance. And this has been very touching and moving with some of our older patients who are just afraid to leave the house. And I completely agree. And they want to know, should they come in, should they not? You're explaining the same things to them. I think they feel cared for because you're taking the time to interact or interface with them. In ocular oncology, you can do a couple things on telehealth. You can take a history, vision assessment, visual field testing can be done. You can do an external examination, but you're limited in terms of the detail of the resolution of the video image. The posterior segment can't really be examined, and you can't really do a lot of ancillary testing. So I think what we're looking at are new hybrid models where patients may come in for data collection and imaging only visits. So limit the time waiting here, come in, get pictures, and then they leave. And then you can do a subsequent video visit that helps to describe what's going on. Much akin to, if I went to my primary care physician, I will get testing done on a separate visit, and then I will discuss that with them. It's not necessarily our perfect model. It's not necessarily how we like to do things, but it is available for our patients, as we go. And then finally, e-pathology is something that I've been very excited about in our practice. So this is the whole-scale digitalization of the pathology slides, and it allows for enhanced clinical care. So we now have a Zoom path review conference, and it also allows for remote diagnosis, and it's great for teaching. Our institution, and no financial disclosures to make here, right before the COVID time was thinking about going live with the system, and they suddenly accelerated this. So we bought a Philips system for digital pathology. It actually allows for scanning of the full entire slide, and you can zoom it up and move it up. Here's a patient with conjunctival tumor, and we could, quickly sort through low resolution, high resolution on stains and scans. And it's actually enhanced my interactions and relationships with my ocular pathology team because we can now bring up pictures, and we have essentially mini CPCs via Zoom on every patient all the time. I should be doing that anyways, but sometimes it just gets busy and I wait for the report because I trust them. But now I feel like I'm an active part in this process. And finally, e-conferences. This is what we're doing here this morning. And it's been a great way and learning from across the globe. The International Council of Ophthalmology held the World Ophthalmology Congress virtually. We had our Bay Area Ophthalmology course that had a ophthalmic oncology section. We created a new CPC conference with our residents because we were looking for ways to change our classroom setting. And now we know that many major meetings are being flipped to a virtual format rather than being canceled. So our story with COVID, continues. Unfortunately, in July, we had a new peak in new cases, but now as we come to August, we're seeing some of these trends improve here in California, but the numbers are staggering, disgusting, scary, and it makes us all, concerned. But I'll say, the most important things in life still need to be considered. Family, here's my daughter who's turning 17 tomorrow. So we had a little distanced birthday at the beach. Here are my fellows who I care deeply about in terms of their training and their progression at a socially distanced dinner that they had with themselves. And finally, it's allowed me to take a little more time to kind of see the beauty in the world around us, which I think is important. So take care of yourself and those close to you. If you're not doing well, then it's hard for you to give the best care to your patients and those that count on you. Stay safe and stay positive. Thank you for this opportunity.
Prithvi, thank you so much for that. And thank you for ending on such a positive note of seeing what are the positives in this time. If we can do that, if each one of us can do that, then we would be building a new world. So thank you for that. There's a question that's come up about artificial intelligence, machine learning, and deep learning as far as their role, Prithvi, currently in the midst of COVID-19.
Excellent question, and we have some outstanding colleagues that are working on just these questions. I think that there's still a lot of work to be done in the role of artificial intelligence, but I will say that the US FDA, the Food and Drug Administration, has initiated a collaborative community concept where they're bringing ophthalmologists, data scientists, experts in AI together across many fields of ophthalmology as instead of individual centers trying to figure this out, bringing it all together. And I'm very proud to point out that one of the main areas is ocular oncology, headed by Dr. Carol Shields. And we have a online session which we can share that information with all the participants. Perfect. Yeah. This is going to be a pretty exciting conference.
I'm intrigued with the, and Prithvi, thank you. You were one of my first residents at Duke, and I'm always so excited to see all you've accomplished in your career. From the day you are truly a sweet person, and I remember the day you splattered betadine all over my white coat and kept trying to pay for the cleaning. I'm curious about the drive-by intraocular pressure checking. We haven't set that up. How is that working out? That's really a great idea.
I'm trying to set up a drive-through scleral depression clinic, but no one wants to come in for that. So I think it's just a way for our glaucoma service to still be able to recognize the lack of comfort many of our patients are coming into first in the United States to go shelter in place. So there's like a very heightened sense of like, we should not be out and about. And they don't want to come in. So this is just another way to try to ascertain vision, intraocular pressure, monitored by a physician, do any reordering of medications. So it's being piloted. We've probably been doing this now for about 2 months. And for the right patient, it seems to work pretty well. I think that there's still limitations, but just like, if I could do we're talking about a drive-through Optos wide field clinic for retina and a drive-through OCT. I think we tried that. That wasn't so easy. But all we want is data, I think, and we can make a lot of good decisions sometimes if we can't fully examine the patient. So these are just, I think people trying to be creative in difficult times.
Those are really fantastic points. Thank you. Thank you so much, Dr. Mrityunjaya. So we're going to move forward to the multiple choice questions by Dr. Jessie Berry. Dr. Jessie Berry is the Associate Director of Ocular Oncology at the University of Southern California Roski Eye Institute and Children's Hospital, Los Angeles. She received her undergraduate and medical degree from Harvard University. Following her residency at the USC Eye Institute, she was Assistant Chief of Service at the Los Angeles County Medical Center at USC. She then completed her fellowship in ocular oncology at Children's Hospital, Los Angeles. She is the founder of Women in Ocular Oncology, and her clinical expertise includes anterior segment, intraocular, and external tumors. Her research endeavors are supported by the National Cancer Institute and focus on development of the aqueous tumor as a liquid biopsy for retinoblastoma, as we already went over. She will be giving the multiple choice questions on next generation, the future of genetics and molecular testing. And I think, Dr. Berry, I think the greatest compliment came in the beginning when Dr. Shields called you the expert. So whatever my words are very weak compared to the words that you've already received.
I agree. Okay, well, I'm also very pleased to be here. As Prithvi just went over, this is such a new and interesting environment. I can hear my 16-month-old daughter having breakfast downstairs, and I may or may not still be in pajama pants. But here we are all together to learn, and I've learned a lot this morning already. And it's been a real pleasure to be part of this powerhouse team. Ashiana, you mentioned earlier, how do you become Carol Shields, which you know, the broader question is how you really hone your career and be an expert in your field. And we don't have time to go over all the answers here, but I think coming together with a wonderful group of supportive people who are in front of you, who can mentor you and lift you up, and then paying it back. So I graduated from, I guess, residency in 2012 and fellowship in 2014. So I'm kind of ending my early career years and going into middle career. And now it's my job to teach and to do outreach and to care about the people who are finishing their training in the same way that I benefited from literally every single person on this slide here and who's been part of this, helping me when I just started out. So thank you to you all for doing that. And then, as I said, the onus is on me going forward. So I do have some research funding, including from the NCI, and I will be discussing some of my research briefly. All right, so let's start out with our questions. The first is a patient, and I think actually without even trying it, most of this has already been gone over, so you guys should be primed. This is a patient, sees Prithvi at Stanford and undergoes a fine needle aspiration biopsy of the lesion below. A chromosome profile comes back and demonstrates monosomy 3. How does this inform the patient's prognosis? Is there a good prognosis for overall survival and for ocular survival? Is there a good prognosis for overall survival, but a poor ocular prognosis? Maybe consider enucleation. Is there poor prognosis for overall survival and poor ocular prognosis? Or does this molecular profile impact overall survival negatively, but not specific to ocular survival?
We're going to hand that question over to Dr. Shigokar, Dr. Makrant Shigokar, to give his best guess on this question.
I think the answer to this question is option B, good prognosis for overall survival, but poor ocular prognosis, and considering for enucleation.
Back to you, Dr. Berry.
All right, so I started out with sort of a tricky one on purpose. The answer for me here is D, that the best data and the best science we have about monosomy 3 is in regards to the development of metastatic disease and the development of that as a cause of death for patients with uveal melanoma, and that it is not specific to ocular survival. However, there have been studies that have suggested that these chromosomal changes can be present in larger tumors, and obviously the larger tumor may impact the overall ocular prognosis. So I, for example, if I tend to do RNA testing instead of DNA testing, but if I got this, I wouldn't necessarily state that the patient needs enucleation, but I would absolutely advise them about the risk of developing metastatic disease. And I don't know, Prithvi, I used you as an example. I don't know if you or Carol or anyone else wants to jump in and say what you do when you see monosomy 3.
I agree with what you're saying, Jesse. It doesn't, that information doesn't change my treatment. You know, it happens at the time of treatment that I get that information, so it's agnostic. But I think it then allows me to risk stratify the patient, consider more frequent screening for metastatic disease, and then consideration of adjuvant treatment trials to try to reduce that risk or entry into other trials.
I would agree too. This is a profile that impacts your systemic prognosis, but not the ocular prognosis.
Perfect. And also to tie this into the time of COVID, this picture was actually from a patient who had vision loss and tried actually for many months to get in to see someone for that vision loss, but kept being told that they just need glasses probably, and that's not something to be seen during COVID, and so was not seen until the patient complained of severe vision loss, and of course was noted to have a medium-sized melanoma, but on the large end of that scale. Okay, very
I think
nicely
we're all
done.
going to hear many of those stories coming up in the next few months, unfortunately.
Yeah, it's not the only I've seen. I agree with you. Okay, so we've gone over this already, but monosomy 3 is a poor prognostic indicator for overall survival because it relates to the development of metastatic disease, and that's been shown throughout multiple studies. Gain of 8q is also another poor genomic or chromosomal marker. Gain of 6p is to be considered a good prognostic marker, again, as it relates to the development of metastatic disease. And as you can see here, I don't know if you see my mouse or not, but down in the bottom right, the regression rate of choroidal melanoma did not correlate with chromosome 3 monosomy status. Okay, let's go on to our next question.
And our next question is going to go to Dr. Sayali Pradhan.
I'm trying to check everyone tiny little bit in these questions. So each one has something that's your outlier trigger. So don't be tricked. Just go with your gut. This is a 37-year-old patient with the lesion shown below. And there is significantly increased metastatic risk if the following mutations are present in the tumor: BAP1, EIFAX, GNAQ or 11, and SF3B1.
Dr. Pradhan, do your best on this question.
It's okay if you're wrong.
Is it C? I'm not sure about this, but is it C?
That's okay. Well, let's go over them all. Okay, so the answer, and you can see here, I put on here whether or not this is in the BCSC, which at least in the US is sort of the baseline for ophthalmic knowledge we use. So the answer here is BAP1. So studies have shown that BAP1 is associated with class 2 disease. It's seen in older patients with a higher level risk of metastatic disease. EIFAX is class 1 and generally shows lack of ciliary body involvement. SF3B1, that was my trick for you. That's with saying the patient was 37 years old. That's seen in younger age patients, generally class 1B. And then GNAQ or 11, those are actually considered to be an initiating event in tumorogenesis. And then the other pathways are exclusive mutations that basically dictate the downstream events. And that was shown in a recent 2016 paper regarding some of the driver mutations. And there's been more and more research done on this to help us better understand that melanoma is not always melanoma. The tumors at the molecular level really are important and impactful to how our patients do. So, but this is something I would say that's probably highly tested, that GNAQ and 11 are initiating events and that BAP1 is a more aggressive driver of mutation. The lesion shown below is most likely caused by a pathogenic variant in the following gene. Most likely caused. A, P53, is that where the mutation is? B, MDM2. C, MYC-N, or D, RB1?
Ma'am, I'm not sure, but I think it's RB1 gene.
Good. Okay, so you recognize that this was what kind of tumor?
Retinoblastom.
Good. That's always the first step anyways in these questions. And you're correct. So 98% of retinoblastoma tumors are initiated by a pathogenic variant in the retinoblastoma tumor suppressor gene. That can either happen as a mutation that's germline and throughout all of the cells of the body, or more frequently, it can happen at the level of that precursor or retinal progenitor cell. And then the second mutation to allow retinoblastoma to take off, of course, happens in the cell, which results in a loss of the tumor suppressor gene. We all know oncogenes and tumor suppressor genes and are very facile with that nomenclature, but the RB1 gene was actually the first tumor suppressor gene described. Basically, the science for that was in the late 70s, early 80s. So within many of our lifetimes, the understanding of cancer tumorogenesis really flipped with this understanding. Now, the trick here was thinking that some of you might have heard, oh, wait, I heard about this MYC-N and MYC-N in retinoblastoma. So MYC-N can MECAN amplification as an oncogene can cause unilateral sporadic retinoblastoma, but in a very rare subset of cases, about 2%. So by far the vast majority are initiated by loss of this tumor suppressor gene. Any questions there? Otherwise, we'll go on to our next multiple choice.
Jesse, can you clarify how you determine MECAN amplification? Is that a blood test or is that a test of the tumor itself?
Yeah, that's right. So it's a test of the tumor tissue itself. This was first described by Brenda Galli's group at Sick Kids in Toronto. And they basically looked through patients with whom they had done testing, serum testing, and had found no retinoblastoma tumor suppressor mutation. And then they looked at the tumor tissue and also did not find any retinoblastoma tumor suppressor gene mutations. And then there was an international collaboration, and each lab who does this said, oh, hey, we have a couple as well. And they were able to show that actually there's very high levels of MECAN amplification. Now, MECAN amplification can also promote tumor genesis, as our group and others have shown, in the setting of retinoblastoma tumor mutations. So it is an important oncogene either way, but the important distinction there is that 2%. Great question. So that's something, well, we can talk about it later, but that's something a liquid biopsy could help with as well. A pre and post-treatment fundus photo is shown. For this tumor, biomarkers for ocular survival have been isolated in which fluid? Blood, CSF, vitreous humor, or aqueous humor? I'm giving the lecture. There's your hint.
The hint is that the Nobel Committee is going to rename it the berry humor in the future.
I'm gonna go with aqueous humor, D.
You took the hint. Very, very good. So this is also in the most current volume of the BCSC. And again, I'm grateful to have been able to participate in this research, but basically this is our attempt to overcome the fact that retinoblastoma cannot be directly biopsied due to concern for seeding that tumor outside of the eye, which changes the prognosis for life for these young children. And we've now shown, as well as independent labs, not just our group, have shown that you can find tumor DNA from retinoblastoma in the aqueous humor. And we have also shown that, like melanoma, there are chromosomal changes that are prognostic. In our case, or in the case of retinoblastoma, gain of chromosome 6p. If you see down here, in red, the red line are the genomic profiles of the eyes that were lost or enucleated, and the blue are the eyes that were saved. And you can see there's a very significant difference in the presence as well as the amplitude of chromosome 6p gain. And if you look at the Kaplan-Meier curve here, you can also see that ocular survival is very dramatically impacted if 6p gain is found in the aqueous humor of these patients. This is still in the research realm. It is not ready for clinical use, although I'm very grateful Dr. Shields and others have agreed to be part of a multi-center trial. So now we have these samples coming in from retinoblastoma patients around the country to inform getting this to the point where we can help these patients clinically.
So a question has come in, Dr. Berry. Is the DNA actively secreted via exosome from the tumor cells or released from dead necrotic cells?
That's a fantastic question. We have some exosome work going on right now to better understand that, although most of the impact from exosomes is in the realm of RNA instead of DNA. All of our DNA is cell-free, fragmented DNA patterns. And as you all know, retinoblastoma is a highly, highly necrotic tumor. So we're finding that I think the most likely mechanism is simple movement of these DNA molecules in a cell-free manner into the anterior chamber. I will say this is unpublished data, but I can share it, that We have been able to isolate DNA in the setting of a group B eye. Now that's an eye with a relatively small tumor and no seeding, suggesting that, again, there is low level of DNA circulating through these eyes. But the highest yields by far, of course, are in eyes that are filled with tumor and filled with seeding. And the difference in the concentration of DNA that we see between this group BI, which was a single eye that we've done so far, and the group E's are nearly 100-fold difference in DNA concentration. The lesion shown below is associated with CNS disease and poor overall survival. Testing for mutations in the following gene can improve diagnosis. Is the gene JAK2, MDM2, MYD88, or the BCR-ABL fusion gene?
I will go with choice D.
Well, that was my trick, so it makes me feel good that I was able to trick, but good job. That, of course, so you're recognizing, I think you're choosing BCR-ABL because you're recognizing that this is a variant of ocular lymphoma, and you recognize BCR-ABL from the lymphoma realm. But the answer is MYD88. So the version is L265P, and it's actually seen in about 85% of cases with primary vitreoretinal or primary intraocular lymphoma, which of course is a variant of diffuse large B-cell lymphoma. And it's a constitutively activating mutation in myeloid differentiation. And so that's why this mutation acts as an oncogene and pushes cells inappropriately through the differentiation pathway. And MID testing has been shown both in the vitreous or the aqueous humor and can improve diagnostic yield. This is a disease where getting cells is sometimes very difficult. And so having this is really quite helpful. I should mention that in most places, this still remains also within the research realm. And then this is actually a picture of the same patient post an alternating course of intravitreal methotrexate and rituximab with really good outcome and clearance of their disease. We've been able to go over some molecular testing for ocular tumors, genomic, genetic, and gene expression biomarkers. We talked about monosomy 3 and BAP1 for uveal melanoma. The vast majority of retinoblastoma is initiated by pathogenic variants in the RB1 tumor suppressor gene. Gain of chromosome 6p is a biomarker for poor prognosis for ocular survival in retinoblastoma, and that remains in the research sphere for now. And detection of MYD88 can improve the diagnostic yield either of vitreous aspirates or the aqueous humor when there's concern for vitreoretinal or primary intraocular lymphoma. And again, in most places, that also remains within the research sphere. Thank you so much. Happy to take any questions.
Dr. Berry, thank you so much for that. Anybody have questions? They can most definitely unmute themselves. I do see a question here. How much of low penetrance RB is categorized with respect to RB1 mutation, present or absent? Does MYCN positive is the same with low penetrance RB?
So most of the low penetrance RB that we discuss is in the setting of known familial mutations. So obviously if you have an RB1 mutation, you have a 50% chance of that mutation being passed on to your future children, but not all of them will develop disease, about 90% will. But there are some low penetrance mutations. There are also some mutations that depend whether they're maternally or paternally inherited, although most of that is more impactful in the genetics counseling aspect for future families and not to how we clinically treat these patients. We make our decisions now based on clinical features.
And what are the comprehensive genetic profiling that you do, Dr. Berry, for ocular tumors?
Do you mean like what do I do for my melanoma patients, or I'm not entirely sure.
Dr. Kumar, would you like to unmute yourself and identify which tumors specifically are you referring to?
Yeah, all the tumors, all the ocular tumors. Comprehensive. Yeah. That's why I'm telling you comprehensive genetic profile. Molecular profiling, you do it for all the ocular tumors, which are FDA approved or it is which are used as a biomarkers. So like that.
Sure. So for me, I think Carol already mentioned she tends to do DNA testing for her uveal melanomas. I tend to do RNA testing. I send my patients for that and determine whether or not they are class 1 A or B or class 2. I use that to dictate some of their surveillance afterwards. I have used the same testing in iris melanoma with the caveat that the test was optimized for choroidal and ciliary body melanoma and not iris, which tends to have an overall lower risk profile. We also do some molecular testing of our conjunctival melanomas. We use the same BRAF and c-KIT mutation panel that is used for cutaneous melanoma at our institution. Conjunctival melanoma and cutaneous melanoma genetically and at a molecular level are much more similar than uveal melanoma, as you likely know. For retinoblastoma, all of our patients have serum testing for the presence of a germline RB1 mutation. The rest of the biomarker work that I do in that setting is in a research setting, but we have published the ability to, that's actually out this month, but the ability to find both RB1 mutations in the aqueous, and from that very same 0.1 milliliter, or 100 microliter, 0.1 milliliter sample of aqueous. We can also do genomic profiling for prognosis, but again, that's in the research field. For this patient, actually, that I showed, the intraocular lymphoma patient, I wanted to do MYD88 testing in the aqueous, but it wasn't available in our laboratory. I don't know if anyone else wants to comment on that, but we were unable to get it as a clinical test. I hope that answers the question.
Do you do NGS or do you do RT-PCR, PCR, something like that?
So for the retinoblastoma, I'm assuming you're asking, it's next generation sequencing. Yeah, so we do next generation, and then we do amplicon-based resequencing of that same library with deeper sequencing for the RB1 mutation.
And what is the ideal time for genetic testing in RB?
So I'm going to assume you mean clinically. And so clinically, for the serum RB1 testing, that really should be done at diagnosis, particularly for a patient with unilateral disease. That's going to be very impactful for how you follow them. You want to know what their risk is of developing tumors in the other eye. And if there is germline disease, which is present in 15% of unilateral patients, that would change the way that you're screening and otherwise following these patients. And then of course, for the patient, there's lifelong impact to having a germline mutation in the RB1 gene.
Dr. Berry, thank you so much. That was fantastic. And you definitely duped so many people, because I think for that last question, there was only one person that answered C and the rest were in other parts. So you definitely duped us all. So we're going to switch gears now from the outer eye to the inner. The next speaker, Dada JP Vaswani, was titled as Saint of the Century, and he was my best friend. He used to teach us that before he left the physical body, that 10 minutes in silence every day, just 10 minutes of going within to find out the purpose of our life, will be the answer to peace and unity on earth. So now in the midst of COVID, we need that more than ever before. So these next 10 minutes of inner sight relaxation are so that we can collectively go within ourselves and share that positivity, those loving vibrations with those who are suffering and are in need in this time. So with that, without further ado, we'll start the guided meditation on inner sight relaxation.
Meditation is the key to living a more rewarding, fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight. As far as possible, let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself in the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at his lotus feet, your arms around his ankles, your head resting on his feet. Say to yourself, here is true rest. Here is true relaxation. Now relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember that all the while you are in the loving, immediate, personal presence of God. We will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest. Expand and relax. Shoulders. Lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. Relax, relax, relax. Let go, and let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for the beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti, Shanti, Shanti.
I hope everyone feels relaxed and has that peace that we can then bring to our different parts of the world and move forward in a very positive
way through the midst of turmoil and tension. Next, we have Dr. Santosh Honavar. Dr. Honavar is the first Indian ophthalmologist to receive the Lifetime Achievement Award by the American Academy of Ophthalmology in 2019, and the highest award of the Royal College of Ophthalmologists UK, its honorary fellowship in 2020. He had received numerous other awards as well, including the prestigious Shanti Swarup Bhatnagar Award by the Government of India. Dr. Honavar currently heads the Department of Ophthalmic Plastic Surgery and Ocular Oncology and the National Retinoblastoma Foundation at the Center for Sight in Hyderabad. Before that, Dr. Honavar headed the Department of Ophthalmic Plastic Surgery at LV Prasad Eye Institute, and thereafter established the Ocular Oncology Service, the first such facility in the country, and added a comprehensive multi-specialty children's eye care center as well. He's extensively published in peer-reviewed journals with over 270 publications to his credit, and his primary research contributions hone in on the diagnosis and management of retinoblastoma and its outcome. He is the current editor of the Indian Journal of Ophthalmology. Without further ado, I hand it over to Dr. Honavar to deliver the White Sea Retinoblastoma 2020. Dr. Honavar, thank you so much for being with us today.
Thank you, Ashiana. I'll be talking about Retinoblastoma 2020. As you look at this slide, you realize that there's been an evolution in the management of retinoblastoma with significant decrease in mortality. In 1990s, we had 98% mortality. From that, we have gone up to more than 98% survival in 2020. That's only because of advances in treatment. In focal therapy, we still do cryotherapy, which is very successful. But as you see in this picture, cryo leaves a very large scar. It's okay to have a large scar in the periphery, but there are complications. Laser photocoagulation produces a large scar and also vascular block in the area where photocoagulation is performed. Currently, we perform transpupillary thermotherapy for small tumors, which leaves a scar which is not larger than the tumor, and the blood vessels that pass through this area of TTT remain patent. So it has minimal complications, and that's the beauty. TTT enhanced, ICG enhanced TTT is a recent addition, where if a tumor were to recur over a non-pigmented scar, where laser take is going to be minimal, or if it does not respond to standard TTT, then we give intravenous indocyanine green and then perform TTT to enhance the effect. You see that the scar is not larger than the tumor itself, but there is a substantial reduction in the size, and there is complete regression at the end of 3 sessions of ICG enhanced TTT here. So in focal therapy, the current principle is less is more. TTT has taken over, and on the horizon are transscleral strontium radiation using a probe and chemoplaque Dr. Brinda Gali is trying to popularize. Plaque brachytherapy is a standard of care for large tumors which are about 16 millimeter in diameter and 8 millimeter in thickness. With a notch plaque, we have access to juxtapapillary tumors as well. Plaque is a easy surgical procedure and produces gratifying results. This is a regress scar 3 years post-treatment. But when you look at it carefully, you find that there is retinal scar involving the entire extent of the original tumor. So we are not actually helping the patient in terms of vision, maybe by plaque brachytherapy, but of course the tumor remains regressed. Plaque is currently used, but for specific indications. But what is new about plaque brachytherapy is that it's been made affordable and accessible by an Indian plaque. This is a totally new Indian plaque, which is made by the Baba Atomic Research Center, which has made the cost of plaque less than 5% of that of the imported plaque, and it's become much accessible to our country. So plaque has specific indications. Chemotherapy did a paradigm change in the management of retinoblastoma. This was the Archives of Ophthalmology 1996 November issue, where a series of 4 articles were published on intravenous chemotherapy as the new modality in the management of retinoblastoma. It was like going back in time, reducing the size of the tumor using 3 drugs, carboplatin, etoposide, and vincristine 3 to 4 weekly, with a much smaller scar than we began with. Example, this is a large tumor that we began with, and after 6 cycles of chemotherapy, the scar that is produced is much smaller than the tumor. Chemotherapy also shrinks the tumor substantially, and the tumor shrinks towards its source of blood supply. Here, supratemporal arcade is the source of blood supply, and tumor has shrunk towards it, leaving macula fovea very early in the course of chemotherapy, thus maximizing visual potential. It also resolves subretinal fluid, thus again maximizing visual potential. So chemotherapy remains the standard of care, but the way of giving chemotherapy has substantially changed. From intravenous chemotherapy that we began with, now we have moved on to intra-arterial chemotherapy. There are other forms of chemotherapy as well, such as periocular injections and intraocular chemotherapy. With intra-arterial chemotherapy, we get access to the ophthalmic artery, and that's done by an interventional neuroradiologist. When we get into the ophthalmic artery, we inject 1 to 3 drugs. Melphalan is the standard drug, but of course, if you have a larger tumor or a refractory tumor, you can add on topotecan and carboplatin as well. Depending on the response to chemotherapy initial cycles, you can add on a particular set of drugs. So maximum of 3 drugs are used, and we begin with 3 drug chemotherapy because we can reduce the number of cycles. The effect of 3 drugs is slightly higher than when we use melphalan alone. This is how is the response with intra-arterial chemotherapy, specifically in group D and group E retinoblastoma. Total retinal detachment regressed with a tumor well calcified. This is one more example of a much larger tumor regressed with intra-arterial chemotherapy 3 cycles, and one more similar example of intra-arterial chemotherapy being very effective in advanced retinoblastoma. Not just in primary retinoblastoma, but for tumor recurrences as this, again, we can use intra-arterial chemotherapy with good benefit. So intra-arterial chemotherapy is the current standard of care for group D and E retinoblastoma and for large tumor recurrences. For vitreous seeds, which were the most difficult component of retinoblastoma to treat, there's been a new understanding in terms of the classification of retinoblastoma seeds. We knew retinoblastoma vitreous seeds as the only form of seeds that were earlier known, but now we have, with OCT guided diagnostics, we have been able to classify these as prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal, and intracameral seeds. Now, intracameral seeds, again, there is a recent understanding in terms of these being depository seeds, which simply come through the zonules and get deposited in the anterior chamber, or infiltrative seeds, which come because of infiltration of the ciliary body, trabecular meshwork, and the peripheral iris. Thus, the seeds get deposited into the anterior chamber. How do we treat these seeds? Earlier, we had radiation as one of the effective ways of managing vitreous seeds. Then came in chemotherapy, intravenous and intra-arterial, which was successful to a certain extent, but there were occasions where we had to do enucleation because of refractory substantial amount of vitreous seeds that remain following intravenous or intra-arterial chemotherapy. Now, when the retinal tumor is viable, we continue to treat this with intravenous or intra-arterial chemotherapy, but we add periocular chemotherapy as well to enhance the intravitreal concentration of these drugs, specifically if you use intravenous chemotherapy. If the retinal tumor has resolved, if only there are residual vitreous seeds, then intravitreal chemotherapy is ideal. Periocular chemotherapy earlier was performed with carboplatin, and currently it is performed with topotecan. This is an example of a patient with focal vitreous seeds here, which have resolved following intravenous chemotherapy and periocular carboplatin. This was a patient with diffuse vitreous seeds, tumor resolved with intravenous chemotherapy, and vitreous seeds calcified with periocular chemotherapy. Diffuse vitreous seeds again resolved with periocular chemotherapy in combination with intravenous chemotherapy. Periocular chemotherapy has about 60 to 70% regression of vitreous seeds along with intravenous chemotherapy. For intravitreal vitreous seeds, which are residual following regression of a retinal tumor, we have intravitreal chemotherapy. This is a patient who was treated with melphalan for focal vitreous seeds, as you see here. Following 3 injections of melphalan, the vitreous seeds have regressed. But with melphalan, we started finding some complications in pigmented eyes, such as Indian eyes. We would find that there is diffuse retinal pigment epithelial change, vitritis, uveitis, posterior subcapsular cataract, and posterior synechiae, thus precluding visualization of the tumor subsequently. It's also given as a weekly injection, making it logistically difficult. So we switched over to topotecan. Topotecan given in 30 microgram 3 weekly is a very gentle drug. It does not produce the retinal complications that we experience with melphalan, but does away with vitreous seeds in 2 or 3 sessions of injections. This is a patient with diffuse vitreous seeds. After 2 doses of intravitreal topotecan, the seeds have regressed. This is again a patient with diffuse vitreous seeds. After 3 injections of intravitreal topotecan, the seeds are calcified. When there is suboptimal response with topotecan alone after 6 injections, then we add in a slightly lower dose of melphalan, 10 or 20 milligram. This combination therapy helps in refractory situations. Example, this patient following intravitreal topotecan 6 injections, there was reduction in the amount of vitreous seeds than we began with, but there was a bunch of vitreous seeds that still remained. After adding combination of topotecan and melphalan, we found that this refractory bunch of vitreous seeds disappeared. One more example of a patient where there were refractory vitreous seeds which went away with a combination of topotecan and melphalan. One more similar example where this refractory seeds went away when we added melphalan. So there's a possibility of adding low dose melphalan to topotecan to treat refractory vitreous seeds. Now, what about anterior chamber seeds? These were clearly indications for enucleation earlier. Now we can treat these if there are depository seeds. That means that there is no iris or trabecular meshwork or ciliary body invasion, which we confirm by anterior segment imaging. Then we can safely provide these children with either intravitreal or intracameral chemotherapy. This is a child with multiple anterior chamber seeds regressed with intracameral chemotherapy with 5 microgram of topotecan. But when there are infiltrative seeds, like this patient where the peripheral iris and the trabecular meshwork are clearly involved, here we have to perform plaque brachytherapy for the iris, trabecular meshwork, or the ciliary body component, and add on intracameral chemotherapy for the loose floating anterior chamber seeds. What about diffuse subretinal or intraretinal seeds? These patients were earlier lasered. Now, laser can produce a lot of scarring. So, transpupillary thermotherapy also can produce a lot of scarring, especially if these subretinal seeds are in the posterior pole, then they will have substantial impact on residual vision. So these can now be treated with intravitreal topotecan. You can see very good effect of intravitreal topotecan on subretinal seeds. You see one more example of the subretinal seeds completely regressed with just injection of intravitreal topotecan. No laser was performed. This is a close-up picture of the same. You can see that substantial reduction of subretinal seeds has taken place with 3 injections of intravitreal topotecan. So RB seeds seem to have been finally conquered. For advanced tumors, we still have enucleation. But the understanding about enucleation is that we have to look for high-risk histopathological factors following enucleation. These are anterior segment invasion, ciliary body invasion, choroidal invasion of more than 3 millimeter in diameter or 3 millimeter in thickness, which is called major choroidal invasion, or optic nerve invasion beyond the lamina cribrosa. If these risk factors are present, then we provide adjuvant chemotherapy. And the effect of adjuvant chemotherapy has been shown in this article, where we found that if we did not give adjuvant therapy, the chance of metastasis was 24%, whereas if we did give adjuvant chemotherapy, then the chance of metastasis came down to 4%. So clearly showing a 20% benefit in terms of survival by just this measure alone. So enucleation is not the end of management of retinoblastoma, it's just the beginning. In orbital retinoblastoma, we have been able to categorize these as primary, secondary, accidental, overt, and microscopic. Tumors which are present with an orbital component at the initial visit without any primary therapy are considered primary orbital retinoblastoma. These can be clinically evident as proptosis, or when you do imaging, you might find that there is extraocular extension, as in this case, optic nerve invasion, which was found on MRI scan. These patients used to have very high mortality. But when we combine multiple forms of treatment in these patients, beginning with high dose chemotherapy, Like this patient who had an orbital retinoblastoma was treated initially with high-dose chemotherapy. I went into thiasis, of course it does, after which we perform a safe enucleation. This is to show orbital component of retinoblastoma regress following neoadjuvant chemotherapy. Eye has gone into a comfortable thiasis. Here we enucleate with a long optic nerve stump, provide stereotactic radiation to the entire orbit, and then do adjuvant chemotherapy as well. So this is a year-long treatment, which is very effective. This is effective even in optic nerve invasion. This patient has optic nerve invasion right up to the orbital apex. Following 6 cycles of neoadjuvant chemotherapy, you can see that the optic nerve caliber has returned to normal, at which point in time you do a safe enucleation and continue stereotactic radiation and adjuvant chemotherapy. This seems to work even for intracranial extension to the cavernous sinus. This patient did have that, and following 6 cycles of neoadjuvant chemotherapy, all that is left is tumor at the superior orbital fissure, which is amenable to stereotactic radiation. Of course, the child would need enucleation and adjuvant chemotherapy. Squamous is a bonus here. These patients don't need orbital excentrations and settle down with conservative measures, non-exentration measures such as enucleation, and can wear a good-looking custom ocular prosthesis with maintained cosmesis. With all these measures put together, we have had substantial reduction in mortality, and current survival in India with these protocol-based management techniques is about 95%. So orbital RB does have a cure. In conclusion, I would say that retinoblastoma management is complex. What is really necessary is individualized management using cost-effective protocol-based techniques with a multidisciplinary team. Thank you so much.
Dr. Honavar, thank you for that brilliant presentation. A few questions for you. The first one, is there a maximum number of high-dose intravenous chemotherapy for RB regression?
There is no maximum number, but generally we don't use more than 12 cycles. Our oncologists, pediatric oncologists are careful in calculating the total dose of these drugs, which are not permitted beyond a point, and that happens to be about 12 cycles.
And have you used intraarterial or intravitreal bevacizumab or chemoembolization?
No, I haven't done that. I don't have any experience with that.
Thank you for that.
I think Dr. Honavar provided an amazing overview of how far we have come in the past 20 years. And this is not just, you know, one city doing it. This is the whole world working together. Everything that Dr. Honavar publishes, I read, because he sees a different cohort of patients than we see in the United States. So whenever we have a patient who might have very advanced disease or in the orbit, we always pull his articles to review. And he was involved in the whole transition to intravenous chemotherapy, then intraarterial chemotherapy. So I just credit Dr. Honavar with all his leadership in India, but not just in India, worldwide, for how much he has taught all of us in the management of retinoblastoma. And we haven't used bevacizumab either.
All of this is so amazing, Santosh. Thank you. I mean, even seeing the expanding indications for intravitreal therapy and the expansion from melphalan to topotecan. I mean, that's something that we will be using this week on the retinoblastoma service at Children's, and being able to look to you and say, oh, look, this was done on 500 patients is something that I think we all are so grateful for.
Another question that's come in, Dr. Honavar, what regimen of RT and adjuvant chemotherapy do you give for RB for orbital extension?
We use the same drugs, vincristine, carboplatin, and etoposide, high-dose chemotherapy. The dose is higher than the standard chemotherapy.
Excellent, excellent. Any other questions for Dr. Honavar?
So for orbital retinoblastoma, then you would use 12 cycles of high dose and then deliver radiotherapy before or after the enucleation?
Just after enucleation, 3 weeks after enucleation.
Okay, around the 3rd or 4th month?
Well, we start with neoadjuvant chemotherapy, which is high dose, and we radiologically monitor regression of the orbital component. Sometimes it takes about 3 cycles for the orbital component to go away. Sometimes it takes 6, and sometimes it even takes 9 cycles of chemotherapy for the orbital component to regress. Only when the orbital component has regressed, then we do extended enucleation. Suppose orbital component does not completely regress with chemotherapy alone, then we go for orbital exentration, and that occasion is very, very rare. So at about, generally by 3 cycles, the orbital component would have regressed. Then you do a enucleation, and within 3 weeks, you start your stereotactic radiation, and rest of the cycles of chemotherapy are given shortly thereafter.
And how do we monitor if the patient gets vitreous hemorrhage after intravitreal chemotherapy?
How do you monitor if a patient gets vitreous hemorrhage?
After intravitreal chemotherapy.
Well, that's a difficult situation because you won't be able to see the seeds anymore. And we have to simply observe vitreous hemorrhage to resolve conservatively. You can't even do vitrectomy in those circumstances. And only after vitreous hemorrhage resolves, then you do further treatment. Otherwise, without visualizing the extent of tumor or the seeds, blind intravitreal chemotherapy is not indicated. Some of these patients, we had to enucleate. This happens, it doesn't happen very commonly, but it does happen that you have a vitreous hemorrhage when the patient is under treatment, and ultimately because of non-dissolving vitreous hemorrhage, you enucleate, and these patients tend to have high risk factors. There's a reason why they have vitreous hemorrhage, perhaps not because of your injection, but maybe because of a necrotic tumor.
What is the efficacy of proton beam in retinoblastoma?
Well, we don't use proton beam. We just have one machine in India, which is very expensive. It's not used for retinoblastoma typically, but maybe Dr. Shields has some experience.
We hardly use radiation at all anymore. I mean, the only radiation that we will use for retinoblastoma, maybe for the past 10 years, has been plaque radiation, which is very localized and is not associated with second cancers. So we don't use proton beam radiation or any form of external radiation. So it's been clearly shown in the literature that any form of external beam radiotherapy is a risk for second cancers. And so the second cancers can be worse than the retinoblastoma. So we don't want to radiate.
Mm-hmm. So Dr. Honavar already answered the question about vitreous hemorrhage with vitrectomy, but the question came in thereafter: is there any role of vitrectomy in retinoblastoma recently?
No, not. I mean, there are studies which have, especially if originating from China, where vitrectomy has been performed for vitreous seeds and resolved retinoblastoma where there is a, scar. But then vitrectomy is not performed when the tumor is active. We give at least about 6 months after the patient has complete regression of retinoblastoma when we do a vitreoretinal procedure for the sake of vision. If at all you have to do vitreous procedure, then you have to have a clear lucent period of 6 months of complete tumor regression. Then you do it for the purpose of settling retinal detachment or, something like that.
And other than decrease in size, what other parameters can be used to indicate regression of the orbital part of the retinoblastoma after neoadjuvant chemotherapy?
Complete resolution of orbital component is what we would like to see radiologically. It does not get calcified unlike intraocular retinoblastoma. Calcification is a sign of regression, whereas orbital retinoblastoma or optic nerve retinoblastoma does not get calcified at all. So complete regression is what you would look for.
And what if the optic nerve involvement persists even after 9 weeks of chemotherapy? Do you go for a planned positive margin?
Right. If we get a positive margin, then we have to give stereotactic radiation, the optic nerve. So that's the part of the protocol.
How about recurrent retinoblastoma post-chemotherapy?
There are many ways of treating it. If the patient has already received intra-arterial chemotherapy, there is possibility of giving additional cycles of intra-arterial chemotherapy. If the patient has received a single drug intra-arterial chemotherapy, you can escalate it to 2 or 3 drugs. If the patient has received intravenous chemotherapy, you can give additional cycles of intravenous chemotherapy or shift over to intra-arterial chemotherapy. So various permutations and combinations. If it's a local tumor recurrence, then might as well plaque it. Small recurrences can be treated with focal therapy.
So we are going to move forward to Dr. Woodward. Thank you, Dr. Honavar. Dr. Woodward is the Chief of Oculofacial and Reconstructive Surgery at the Duke University Medical Center. She's Professor of Ophthalmology and Associate Professor of Dermatology, Fellowship Director of AS-OCT, the American Society of Ophthalmic, Plastic, and Reconstructive Surgery. She has delivered keynote presentations for conferences in South America, Asia, Europe, and the Middle East, as well as various domestic conferences. And she is also on the editorial board for 3 aesthetic journals. She will be giving us multiple choice questions on what's that, eyelid and orbital tumors. So Dr. Woodward, thank you so much for being with us today. It's such a great honor to have you and to see you again after so long.
So much. Thank you so much, Dr. Narayan, for having me on this panel. I've been really excited about it. I'm at Duke in North Carolina. I've been here for 20 years, and we had an earthquake here today. You may read about it in the news. It's the first one they've had in almost 100 years, and the epicenter was a couple hours away, but so far as we know, everybody's okay. And my international reputation, like she said, is more aesthetics. But I keep my practice only about 40% cosmetic and about 60% reconstructive and functional, because I really feel committed to taking care of patients with cancers and real disease. So that's just a bit about my background, and this panel is absolutely amazing. I'm totally honored to be a part of this stellar group. Which of the following is the most common lymphoma encountered in the orbit and ocular adnexa? A, plasmacytoma, 2, follicular lymphoma, 3, marginal zone lymphomas, or D, mantle cell lymphoma?
For Dr. Margaret Hubble?
I'm going to go with marginal zone lymphomas.
So yes, it's marginal zone lymphomas, and we published a paper out of Duke with our pathology team where we analyzed 115 lymphomas of non-Hodgkin's B cell, and we found that about 54% of them were marginal zone, which is fortunate because they are a little more differentiated and fortunately have a slightly better prognosis. And these were some pathologies from that paper, the reactive follicular hyperplasia on H&E and then CD20 positive. And the WHO has reclassified these. This was from the classification system in 2008, and then they redid it in 2016. They have reclassified again. And if you look at all the classifications, there's about 70 different types of lymphoma throughout the body, but little has changed in the orbital area per our ocular pathologist, Dr. Proya. And for the non-Hodgkin's lymphomas, they tend to be more in the elderly, most common orbital malignant tumor in these older patients, and can be confined to the orbit or systemic in about 50%. And so you can see as the differentiation pattern goes on, those marginal lymphomas fortunately are more differentiated. So like I said, they have a little better survival, and lymphomas like the mantle cell may not have quite as good of a survival because they're higher up in the chain. So just a clinical pearl about lymphomas that I've noticed in my experience over the years is that they can have a very odd indolent presentation. So I have seen optometrists chase them with multiple prescriptions of prisms and glasses. I've seen strabismus surgeons chase them with strabismus surgery, and I've seen them referred in for ptosis repair and blepharoplasty repair. So they can have this kind of slow indolent presentation. And another quick pearl is that the patients are terrified when they hear the C word, the cancer word, which you all are very familiar with. And I just try to encourage them that the chemo tends to be very well tolerated. They don't always lose their hair. So at least in that interim until they start their care, they're not totally as terrified. So I just want to share an example of a patient who was referred for a ptosis repair, blepharoplasty valve. I took one look. Didn't look normal. She had these solid masses that I could palpate in both of her upper lids. The upper lid had kind of an unusual contour on the left. And I thought, oh gosh, this is not a typical blepharoplasty valve. Didn't want to waste time getting a CT, so we just elected to do a quick B scan and saw these translucent masses above the globes in both eyes, swept her back not to waste any time in our minor procedure room, and immediately were able to get tissue, so we had no delay in care. So that's a pearl. If you can feel it, you can often biopsy it in your office right away. And these were not her scans, but some very similar scans showing the molding, pancake-forming shape of lymphoma, T1 and T2 hypointense. And the frozen section came back as marginal zone, which was encouraging. However, unfortunately, her final diagnosis was mantle zone with the CD5 positive. And here she is after all these treatments. 6 years later, she came in just 3 weeks ago. And you can see her tumors have regressed. She's doing great. She has no recurrence so far. And she was complaining about having to wear a mask. What's that? An orbital schwannoma, an orbital neurofibroma, a meningioma, or a lymphoma?
Dr. Kelly Donovan.
Hi, I'm here. I'm actually just a medical student, but I would guess maybe
D.
Well, I'll tell you, she actually had a meningioma. And this is just a brief case I want to show that they can be optic nerve sheath or sphenoid wing, which this patient had. They can arise from the arachnoid cells, and they're 4 to 8% of the orbital tumors, more common in women, and they can be radiated, and however, they can return with a malignant transformation. So this patient wasn't radiated, but we did do a craniotomy. We debulked as much tumor as we possibly could, and then we placed a titanium plate, which is a little flexible, allows for expansion. And fortunately, she had a WHO grade 1 with Pseumomatous bodies. And this is what she looked like after surgery. And the clinical pearl here is just to think about the patient's whole being. She was very distraught about her appearance, her eye looking swollen, still a little bit proptotic. So what we did for her was offer her aesthetic surgery. So this is the balance, where she had a 4-lid blepharoplasty, fractional CO2. We did 5 to 6 passes on her festoon on the right lower eyelid, 100 spots per square centimeter, and she's back to being a beautiful woman, which she really was inside and out, feeling more like herself, and so she was very happy. Still doing well. What's that? An orbital schwannoma, an orbital neurofibroma, a cavernous hemangioma, or both A and B?
Both A and B. D. This is Margaret again.
Oh, very, very
D.
clever. A and B, a bit of a trick. Yes, so this patient had a combined tumor, and you can see the difference here where schwannoma is a peripheral nerve sheath tumor and also combined with a neurofibroma, which was an endoneurial tumor. And it came out like this amazingly beautiful ball and had this interesting stalk on it. And we were very happy. It was removed very uneventfully. She did great. And then the pathologists were very excited about the hybrid component of it. So we published a paper with this. And just to go through the 2 types, the orbital schwannoma is rare, usually in the head and neck, can be seen in NF1 patients, and rarely undergoes malignant transformation. The CT can show smooth elongation, a little calcification with spindle-shaped cells, and typically extraconal. It has the Antony A and Antony B areas, which can also be seen on MRI, and it deforms tissue as opposed to the lymphoma that I showed you that has the pancake molding. And then the pathology shows the Antony A and Antony B classic myxoid, and can also show 4 subtypes in the pathology. Quickly to go through the neurofibroma component, 2 to 4% of orbital tumors can be plexiform, associated with NF1, diffused or localized. Looks like the bag of worms with eyelid involvement, the big S-shaped deformity, and 20% can have a malignant transformation in NF1. So the CT isodense to the muscles at T1 and T2, low, moderate, and moderate high signaling. And clinically, this is a classic little baby. She had a huge one. This was my result after surgery, challenging case. But what's tough about neurofibromas isn't just that they're very vascular and bleed, but they're not separate from the orbital tissues. They infiltrate everything. So her tarsal plate, instead of being 9 or so millimeters, is a 15 millimeter tarsus. So the way I tackle these is you have to do a full thickness blepharotomy. Here she is on the table with all other symptoms of neurofibromatosis. And there's a little video there showing the pulsating proptosis from sphenoid wing hypoplasia in another patient. But basically, sometimes I'll use the CO2 laser. Sometimes it's not enough. I'll have to use other modalities like a monopolar cautery, but we'll do this excision, full thickness, as well as take out a lateral wedge of the entire upper eyelid. And that's how we'll get a result on a patient like this, hopefully avoiding some amblyopia, but they're challenging resections for sure. So the pathology can show a pseudocapsule. The nuclei may be fusiform, elongated, or comma-shaped. They may have the Rosenthal fibers. Back to this patient's interesting case, the tumor grew back 2 years later. We went in to take it out again. The second time, it wasn't exactly a beautiful ball like this. It was kind of mushy, a little bit more the neurofibromatous type component. And so we resected it again, and it grew back a little bit more. And we've basically just been following her now for about 14 years, and it hasn't grown. She's probably somewhere on the spectrum of neurofibromatosis. She has one also in her jaw, but she doesn't have any other symptoms causing her any problems, and she's been very stable. This is her photo about 1 month ago. So she's holding her own for about 14 years. We're gonna buzz through these because I think we're out of time. I really wanted to stay on time for you guys, but just a couple of quick flybys. This is never mistake a chalazion for sebaceous cell carcinoma. I biopsy these the second they come into the office. We don't waste time. We get it done right while they're there. And this is showing a reconstruction with the Cutler beard flap of the patient where we pull up the conjunctiva, put on auricular cartilage, and then pull the orbicularis and skin over that and split it a few weeks later. And this is this patient's function after having that surgery. She's comfortable, she's doing well. I've been really happy with this procedure if you just do it just right. And then also I gave a 1-hour lecture this morning on to a dermatology group. We were talking about biochemistry of hopefully preventing some skin cancers. And there's some topical antioxidants and other things that you can use to prevent thymine dimers and DNA mutations found in squamous cell carcinomas that I'm a huge fan of. And some of these things can be seen to prevent apoptosis and erythema, sunburn, and cells without using sunscreen. And so those are two of my other passions. And there's my beautiful family. And thank you so much for allowing me to be a part of this spectacular group.
Dr. Woodworth, thank you so much for that spectacular
Does
talk.
anybody have any questions?
That was excellent. That was excellent. If questions come on, feel free to post them on the chat. And we're going to go forward to Dr. Nandan Shetty. Dr. Woodworth, thank you so much. So Dr. Shetty received—
You're welcome. Thank you for having me.
It's been great. Really great to see you. So Dr. Shetty received both his BS and MS at SETGS Medical College in Mumbai. He was a retina and vitreous fellow at LV Prasad Eye Institute in India and ocular oncology fellow at Jules Gonin Eye Hospital in Switzerland. He is a consultant ophthalmologist for Tata Memorial Center, Jaslok Hospital and Research Center, and Sushruta Citizens Cooperative Hospital in Mumbai. In the tradition of 2020 ophthalmology course series, we look at the most scientific data on the topic, and Dr. Shetty will be giving us the finale talk, 2019 to 2020 Ocular Oncology Publications. Thank you, Dr. Shetty.
Thank you, Ashiana. It is truly an honor to participate in today's webinar, and I would be speaking on publications in ocular oncology over the past year and a half. PubMed research over the past year and a half showed the maximum number of publications for orbital tumors, and this was followed by intraocular tumors, and then eyelid tumors, the least for surface tumors. Of these, I will be presenting a few articles which could impact our practice of ocular oncology. This talk would be incomplete without a mention on a couple of articles touching upon ocular oncology practice in the COVID-19 pandemic, some of which has already been discussed, but these are the articles which will guide us to go through, carry on with our practices. So in April 2020, Alison Scarlett and co-authors, and a couple of the co-authors are present in today's webinar, they came out with a paper in the form of a letter to the editor, titled Considerations for the Management and Triage of Ocular Oncology Cases in the COVID pandemic. And they broadly classified patients as emergent, urgent, semi-urgent, and non-urgent in decreasing order of urgency. It was in July 2020 issue in the Indian Journal of Ophthalmology, an article by Feroz Manjua-Dada, Santosh Manohar, and Usha Kim was probably the most detailed advisory on this matter. And they have described triage at 4 levels, in which triage 1 and triage 2 are before the patient reaches the clinic, and triage 3 and level 4 triage are when the patient actually reaches the clinic. They have given detailed tumor-specific guidelines for almost all intraocular tumors, namely retinoblastoma, choroidal melanoma, intraocular lymphoma, as well as for eyelid tumors and orbital tumors and conjunctival tumors. They have concluded saying that the management of ocular malignancy should not be delayed or deferred as compared to benign tumors, because late diagnosis will lead to disease progression and a poor prognosis. More so, however, they are saying that it is a belief that the virus is here to stay and that we have to coexist carefully. So, The next topic is on ocular surface tumors. It's on the use of, that article is on the use of high resolution optical coherence tomography in the surgical management of OSS. And this was a pilot study by Professor Carol Cart and co-authors, published in American Journal of Oncology last year. And it was a prospective study on 8 eyes of 8 patients who were planned to undergo surgery. A high resolution OCT was done immediately before surgery, and the conjunctival margins were identified. Here you can see the abrupt transition from a thickened epithelium to a normal epithelium. Tumor border, as per the high resolution OCT, were mapped and transferred intraoperatively. The tumor was excised with 4 mm margin using no-touch technique. And the histological tumor margin were compared to the high resolution OCT predicted tumor border. The conjunctival tumor margin identified with high resolution OCT coincided with the pathologically confirmed margin. Another example where you can see that the conjunctival tumor margin identified with the high resolution OCT here coincided with the pathologically confirmed margin. So the benefits of using OCT in OSS in surgery are you can get a complete removal with clear margin, reducing the risk of recurrence. And in extensive OSS cases, you can actually conserve limbal stem cells and reduce simplification operation. So this opens up the possibility of a future era of OCT guided surgical excision with the use of integrated HR-OCT system, and this has been compared to what you can call an optical MOS. The next article also on OSS is a comparison of topical 5-fluorouracil and interferon alpha as primary treatment modalities for OSS. This was published in American Journal of Ophthalmology last year by Nandini Venkateswaran and co-authors. In this retrospective case series, 54 patients received 5-fluorouracil and 48 patients had received interferon alpha topical. And the primary outcome measure was frequency of clinical resolution and time taken to OSS in recurrence. The secondary outcome was frequency of side effects. Here we can see in the Kaplan-Meier survival graph that both modalities, topical 5-fluorouracil and interferon alpha, achieved a near equal time to clinical resolution. So, concluding, both modalities resulted in a high frequency of tumor resolution and low recurrence rates. And this particular study is pertinent in practices where interferon therapy, cost, and strict storage needs could influence treatment choices in favor of fluorouracil. The next topic for discussion for article is on uveal melanoma. This particular study has already been mentioned by Professor Carol Shields, so I will skip this for avoiding repetition. And just giving the conclusion of this study, the cancer genome atlas classification of uveal melanoma makes prognostication of uveal melanoma simple and highly predictive. And this will be helpful in selecting patients at high risk for adjuvant therapy protocols. The next article on uveal melanoma is on visual outcome at 4 years following plaque radiotherapy and prophylactic intravitreal bevacizumab every 4 months for 2 years for uveal melanoma. This was published by Carol Shield and co-authors in JAMA Ophthalmology this year. This was a retrospective, non-randomized interventional study in which 1,131 eyes received bevacizumab and 117 eyes did not receive. And prophylactic bevacizumab was injected at the time of plaque removal plus 6 subsequent injections at 4 monthly intervals over 2 years. The result was better visual outcome in the treated group through the 4 years follow-up. They have concluded that radiation retinopathy-related vision loss can be avoided with prophylactic anti-VEGF treatment. And a nomogram to predict the same is available on fighteyecancer.com/nomograms. Moving on to retinoblastoma. The study I've selected here is a study of unilateral retinoblastoma with and without histopathologic high-risk factors and the role of adjuvant chemotherapy. It's a COG study which was authored by Patricia Chavez-Berrios and co-authors. In this study, it was a multicenter prospective study with 331 patients enrolled, and there was a central histopathological review in 321 patients. They found out that there was post-laminar optic nerve invasion in 53 patients, massive choroidal invasions in 42 patients, peripapillary more than 3 mm choroidal invasion combined with cloney in 15 patients, and focal less than 3 millimeter choroidal invasion and laminar and pre-laminar optics involved in 15 patients. They showed that concomitant less than 3 millimeter choroidal and any pre-laminar or laminar optic nerve invasion shows no recurrence and may warrant no adjuvant chemotherapy. In contrast, concomitant more than 3 millimeter peripapillary choroidal invasion plus more than 1.5 millimeter of post-laminar optic nerve invasion have the poorest prognosis and will need a more intensive adjuvant chemotherapy regimen. The next paper on retinoblastoma is pars plana vitrectomy under melphalan irrigation for recurrent retinal detachment in eyes treated for retinoblastoma. This was published in BMC Ophthalmology and authored by Christina Statopoulos and co-authors. This is basically a case report of two patients, a girl and a boy, both 7 years old, who had scleral buckling surgery done for rheumatologic larvae and who later had developed a traction larvae. Both patients were managed successfully by pars plana vitrectomy under melphalan irrigation with good postoperative vision and no retinal detachment and no tumor recurrence. The last article for discussion today is on intraocular lymphoma, biomarkers revisited. This was published by Suprachoroidal Sharma and co-authors in IOES of June 2020 issue. So, intraocular lymphoma poses a serious diagnostic challenge, and it often masquerades as uveitis or white blood syndromes. And the gold standard for diagnosis has been identification of malignant cells in the vitreous, and this is often inconclusive because of the fragile nature of the cells. And there is a need for a rapid and reliable biological marker for early diagnosis. So in this study, 77 patients undergoing and diagnostic vitrectomy specimens were assessed within 1 hour of the pars plana vitrectomy and maintained in a cold chain. The studies done were for cytological examination, flow cytometry, cytokine profile analysis, and gene mutation studies for MYD88. MYD88 is a driver gene which, when altered by mutation, can promote oncogenesis. And the position L265P indicates a missense mutation in which the leucine at position 265 is changed to proline. In the results, they found that 13 out of 77 patients were confirmed to have primary intraocular lymphoma, and initial cytology was indeterminate in 4 out of 13 patients. They found raised levels of interleukin 10 with the interleukin 10 to interleukin 6 ratio of more than 1 in 12 out of 13 eyes. Concluded that predominant presence of B cells along with a raised interleukin 10 to interleukin 6 ratio of more than 1 is as a powerful tool for clinical diagnosis of intraocular lymphoma. And further, if you can get the gene mutation studies and MYD88 mutation is present, can strengthen the diagnosis further. That's all for today's session. Thank you.
Dr. Shetty, thank you so much for the most arduous task of going through the entire literature and giving us the highlights. I want to thank everyone for being here with us today. I think that this was really a time to come together and really learn from each other. And I know I have to go back to the recording and listen to each one of you 3 times over at minimum to really take the pearls that you've taught today. Thank you for sparing your time to the participants and to the faculty for bringing in your expertise. I know how busy you all are, and it means a lot that you've come here today to teach us. So with that, I hope for many, many more opportunities of learning together. And I look forward to the time when we'll be maskless, where we can actually see each other's face and where we can be together, hopefully in a future meeting or somewhere in the world very, very soon. Stay safe and be well.
Thank you.
Thank you.
Thank you all. Bye.
Bye.